arms, 1:1:1. Control arm, which is a specific control arm where patients get durvalumab, but also the addition of other drugs, durvalumab and oleclumab or durvalumab and monalizumab. And this is 60 patients per arm, and it was published, and you can see the curves showing that the addition of these two drugs, in addition to durvalumab, after the completion of chemoradiation, improves survival. And AstraZeneca is pursuing this in an ongoing phase 3 trial right now. There's data from MD Anderson and other institutions in the state of Texas for patients with early stage lung cancer where they got immunotherapy followed, or they got stereotactic radiation therapy followed by immunotherapy. This is a phase 2 trial. It was 156 patients with stages 1 and 2. They were randomized 1:1. They got stereotactic radiation with or without nivolumab within 36 hours of delivering the SBRT, and their primary endpoint was 4-year event-free survival. They either gave 50 gray and 4 fractions SBRT, or for more central tumors, they gave 70 gray and 10 fractions, and these are their results. Again, these are early stage patients, medically inoperable, but the event-free survival was 77%. Quite good, clearly benefiting from the immunotherapy drug given after completion of SBRT. And you can see on the plot to the right that every patient benefited, all types of patients benefited from this. Yet in the past year, we have a series of trials that are all negative. When we thought we had the idea that we would add immunotherapy concurrently with radiation or radiation and chemotherapy, and to date they've all come out negative, including Pacific 2, which I was a principal investigator, the small cell trial called Energy Alliance, LU005. There's an early stage trial from the Southwest Oncology Group and NRG, and also a BMS trial. I'll show you the data. So this was Pacific 2. Patients were randomized. They were locally advanced, node positive, non-small cell, randomized 2:1 to receive durvalumab or no immunotherapy. I said earlier that not the whole world adopted durvalumab after the progression-free survival curves were published. Some countries waited until the overall survival benefit occurred. There was a 2-year window there. So this trial ran within that 2-year window. So the control arm of this trial had no immunotherapy involved. The endpoint was progression-free survival, and we did not see a progression-free survival benefit. There was no benefit to concurrent IO and radiation followed by consolidation IO. These are the overall survival curves, no difference. We just presented this trial at our recent ASTRO meeting in the United States in Washington, D.C. It's a phase 3 trial for patients with limited stage small cell lung cancer. As you know, atezolizumab is used, and it is commonly used, either atezo or durva immunotherapy with patients with small cell lung cancer. It was recently published at ASTRO, or presented at ASTRO, that the addition of durvalumab after completion of chemoradiation offers a survival benefit. So back in 2019, we had the idea we would add immunotherapy concurrently with chemoradiation in limited stage small cell, and we accrued 544 patients across the US and Japan. Patients were randomized 1:1 with concurrent and consolidation atezolizumab. The primary endpoint was overall survival. I'll show you the progression-free survival curves, no benefit. The overall survival curve, no benefit to the addition of concurrent immunotherapy and consolidation immunotherapy. Looking at toxicity, this is part of why the patients, we had more toxicity, more events in Pacific 2 and LU005. When those events occur, the patients stop taking the drugs. So there's less cycles of immunotherapy given, in the concurrent arms of both of those trials. And that's part of the reason for the negative effects, we think. At the same time, Merck released a press release this past year, August, of a trial with stereotactic radiation, early stage, where they gave SBRT plus or minus their drug, pembrolizumab, and at the first pre-specified interim analysis, Keytruda in combination with SBRT did not demonstrate an improvement in the primary endpoint, which was event-free survival, and the trial was stopped. And this is all we know about it, is this press release. We have not seen the data to understand why this trial was negative. Now, I showed you the data from MD Anderson that it was very positive. So this is a surprise to us as to what happened. I don't know what happened. We ran a trial within Energy Oncology and the Southwest Oncology Group at the same time. These are patients with stage 1 and 2 non-small cell, and this was a phase 3 trial randomizing radiation alone. Again, this is stereotactic radiation, so something like 3, 4, or 5 fractions of radiation for peripheral lung cancers versus giving upfront atezolizumab for 2 cycles, followed by consolidation atezolizumab. This trial has been submitted for abstract at ASCO. It was stopped early at its first interim analysis, or its second interim analysis, showing no benefit to the drug. I can't show the curves because we submitted to ASCO. There's another study called Pacific 4, where RTOG partnered with AstraZeneca, where we gave SBRT followed by durvalumab in this case versus placebo. This is a trial with 630 patients. It has accrued. It's stopped accrual, and we're awaiting events, so I don't have results from this. But the endpoint's progression-free survival. We're hopeful it will be positive like the MD Anderson trial was, because it was the same. It's a different drug, but the same schema and the same very little difference between the two. So we're seeing heightened toxicity with concurrent immunotherapy approaches and radiation therapy, and loss of efficacy with concurrent immunotherapy compared to consolidative immunotherapy approaches. So how can we adapt our radiation approaches to best synergize with immunotherapy? One thought we've had, there's a few publications on this, something called EDIC, or estimated dose to immune cells, estimated radiation dose to immune cells. Let's say you treat a large central tumor and you're irradiating lymphocytes, which are very sensitive to radiation. You're negating the effect of immunotherapy. So if you're giving those two things at the same time, they're working against each other. And we've run this a couple of times. This one is from a data set from Emory University, where we looked at 100 patients in the immunotherapy era, showing that the estimated dose to immune cells shows a marked difference in whatever metric we decided to look at, patients receiving immunotherapy. We've also looked at that in a trial I ran called RTOG 0617, showing EDIC was extremely powerful. And we are now looking at it within the Pacific 2 database to see if it explains what's going on when you add immunotherapy and radiation therapy at the same time. Those two things are working against each other. So I was asked to talk about the abscopal effect, and I wondered who was asking about the abscopal effect, because this must be a radiotherapy session in the conference. So this is an actual patient. It's a patient with T2A into M0 squamous cell carcinoma, where the pathology confirmed that that lymph node in the station 4 was positive, but the radiation therapy volume only treated the peripheral lung cancer and not the node. The yellow line there is 24 gray, yet the patient went to surgery and the patient had a pathologic complete response in the lymph node. So that is the abscopal effect, and it does occur. So what are some innovative approaches to radiation therapy we can think about to spare dose to immune cells and lymph nodes? Can we de-escalate the radiation dose to nodal disease? For patients with PD-L1 high cancers, can we completely exclude nodal disease? Is there evidence for the abscopal effect in lung cancer? What is the abscopal effect? It's an effect that occurs when radiation treatment or another type of local therapy not only shrinks the tumor that's within the radiation therapy target, but it leads to shrinkage of untreated tumors elsewhere in the body, just like the lymph node I showed you. And we're definitely seeing this more often with immunotherapy. Here's a paper. There's more papers coming out about it. This is a paper I found where the more heterogeneous dose you give, the more dose variation within the target you get, the higher the abscopal effect, and this is in mice. So there's thought that maybe heterogeneity of radiation dose might help the abscopal effect. This is a trial run out of Albert Einstein in New York. Patients, Dr. Altorki was the lead author. He's a surgeon, a thoracic surgeon there, was the lead investigator and author, and they gave neoadjuvant durva with or without stereotactic radiation therapy in patients with early stage non-small cell lung cancer prior to a planned surgery. So these are patients with stage 1 to 3A disease, good performance status, and they did not have an actionable target. And they were randomized 1-to-1, these are 60 patients, to receive durvalumab for 2 cycles or 8 grade times 3 to the primary tumor, excluding the lymph nodes, not treating the lymph nodes in the radiation target, restaged, and then had surgery. And if you look at the results, arm B, which got the radiation therapy, the maximum pathologic response was 54% versus 6.7%. And the pathologic complete responses went from 0% to 26.7%. So this is a trial proving that there is an abscopal response when you add immunotherapy and radiation therapy. And these are subablative doses of radiation therapy. 8 grade times 3 is like half of the dose you would expect to cause complete eradication of the tumor. And you can see as tumor responses, the red is the addition of SBRT to the immunotherapy. You've got enhanced tumor responses in the waterfall plot. So there are ideas about challenging the standard of care in operable or perioperative chemoimmunotherapy versus immunotherapy with SBRT. I think you'll hear about this in the next session, which is a lung cancer session. I know Dr. Illiman is going to touch on this, but we've had a number of trials in the operable early stage space for patients with node-positive disease getting chemotherapy and immunotherapy prior to a planned surgery, and that's changed the paradigm in operable stage 3, stage 2 and 3 non-small cell, and we're seeing pathologic complete responses at the time of surgery ranging from 17 to 25%. There are some ideas for studies out there. This study is a follow-up study to Dr. Altorki's study where they're randomizing patients with stages T2 to 4, N0 to 2 disease without an actionable EGFR ALK mutation to receive, in this case, cemiplimab, so 8 grade times 3 with cemiplimab versus a control, which is chemo-IO followed by surgery, with the primary endpoint of complete pathologic response. This trial is ongoing. Again, it's 8 grade times 3, subablative doses, just to the primary tumor, not to the lymph nodes. The Alliance is running a trial within the National Cancer Network. It's for patients with oligometastatic disease, immunotherapy and chemotherapy versus the same, plus the addition of stereotactic radiation. They're using 8 grade times 3. So people are testing this in larger trials now. So in summary, Pacific changed the treatment paradigm in 2017 and eventually showed a 5-year overall survival benefit with the 5-year numbers being 43%. At MD Anderson and in other places in Texas, iSaber showed an improved event-free survival in early-stage disease with immunotherapy after stereotactic radiation. The trials to date looking at concurrent chemoradiation with immunotherapy are negative in non-small cell lung cancer. And this past year, and we're still trying to figure out, that's what I mean by the data are evolving here. Many trials are pending, including Pacific 4, testing IO after SBRT in early stage disease, and some upcoming trials are testing a new paradigm, subablative doses to prime the immune response prior to immunotherapy. Thank you.
It's not working. Thank you, Dr. Bradley. Dr. Yusuf Katib will introduce the second speaker. Dr. Yusuf is a senior consultant and professor of radiation oncology in Taiba University.
Assalamu alaikum. Thank you for the organizing and scientific committee. So our second speaker is Dr. Mohammed Al-Haim. Dr. Al-Haim is a consultant radiation oncologist at King Faisal Special Hospital in Riyadh. And he will give us a presentation about utilizing precision radiotherapy to improve the therapeutic ratio. Dr. Al-Haim, mic is yours.
Assalamu alaikum. Can you hear me? My voice clear? Good. My name is Dr. Mohammed Haim. I'm a consultant radiation oncologist in King Faisal Special Hospital in Riyadh. And first, I would like to thank the organizing and scientific committee for giving me this opportunity to talk to you today. And special thanks to Dr. Amal Al-Bihani for this great organization for this second year conference. I'm going to speak about utilizing precision radiotherapy to improve the therapeutic ratio. And I understand the diversity among the audience, so I'll try to make very simplification of the radiation concept. There might be some company's name in my presentation, but I have nothing to disclose and no financial relationship with those companies. So I will speak about the historic progression of radiotherapy in the last 100 years, and then what's the key technological advancements that improve the precision of radiotherapy, like image guidance radiation, intensity modulated radiation, VMAT, SBRT, proton therapy, and MR-Linac. What's the artificial intelligence role and impact in our fields as well as in patients' care? What are the challenges and future direction in the field? Therapeutic ratio is a central concept in radiotherapy. It explains the relationship between the tumor control probability and normal tissue complication probability. So for a given dose, there are a discrete probability both to the tumor control and normal tissue complications. And this relationship defines the therapeutic ratio. The larger the ratio is the more effective treatment and safer treatment. And the narrow ratio is the worst treatment outcome. There are various factors can influence the therapeutic ratio, such as some of them are related to biology, which is beyond my talk today, related to intrinsic radiosensitivity and the capacity of sublethal repair. And there's some factor related to physical and anatomical factor like proximity of tumor to critical structure. And we can alter probability of the treatment, and then we can modify the therapeutic ratio and improve the likelihood of the successful treatment. So 100 years ago, radiation evolved rapidly. So in the 1927, I think this is the year where the linear accelerator was born. And then the concept of utilizing proton radiotherapy was back in the 40s by Dr. Wilson, and then the first proton used in clinical scenario was in Berkeley in the United States in the 50s. Lexel lead the work with the radiosurgery back in the 60s with the gamma knife, and then once the CT scan developed in the 70s, being readily utilized to adopt and start to use in radiotherapy. And then in the 90s, there is the intensity modulated radiotherapy developed. In early 2000, we have the image guidance radiations, volumetric arc radiations, and then the proton and intensity modulated proton radiotherapy was in 2008, first in MD Anderson. So for the non-rad-onc audience, this is usually the flow of patients in radiation oncology clinic. We see the patients in consultation, and then if patients need radiation, we do the simulation scan, and then target delineation, organ segmentations, treatment planning, we review the plan, and then patients will be ready to receive the radiotherapy. I would like to show you some of the work that we did in King Faisal in our hospital in Riyadh, trying to improve the radiotherapy process and improve the precision of radiation oncology. For the consultation and image simulations, we have used the virtual reality. We utilize 3D 360-degree video that we created mimicking the whole clinic situation in our department, as well as simulating the simulation process exactly. We use the virtual reality goggles to display the product for our patients to enhance and boost their educations and knowledge about radiotherapy. This in the video is our first graduate, Dr. Al-Dakhil, first local resident graduate from local residency program in Saudi Arabia. He's the one leading this project. And what we did, we start to collect data. We randomly select some patients in our department. Majority are being female, various age group, different education level, different marital status. But what we noticed that using virtual reality in clinic, in fact, improve the patient satisfactions, improve the knowledge about the radiotherapy and the simulation, and reduce their anxiety score. Also, some of the work we did in improving the target delineations. So we had 236 MRI image for brain glioblastoma. We treated those patients with radiotherapy in our department 2017-2021. Half of those, they have our selected criteria having a very thin slice of 1 millimeter of T1 contrasted image, MR, and then we contour the gross tumor volume on those T1 enhanced MRI image. And the gross tumor volume was created and approved by a consultant radiation oncologist who specializes in CNS tumor. This is axial cut of MRI T1 enhanced slice showing ring enhanced lesion in the right hemisphere of the brain, and the red is the contouring that's done by the radiation oncologist. So we adopt and use a machine learning model that develop and train for auto-contouring the gross tumor volume. So we use automated pipeline and validate for, that was validated for high resolution 3D volumetric segmentation of MR image. And we're using famous system called 3DUNet that supervise the deep learning architectures. And then we pre-process image using Z-score normalization for the contrast in the T1 weighted MRI. And then we do 6-fold cross-validations to separate the dataset sample. We try to figure out the dye score and the cross-entropy, and I'll just explain this shortly. So this is the key fold cross-validations that we use to enhance and robust our model. And then the dye score is usually used to quantify the performance of the image segmentation method. And usually if we said dye score of 1, this is the greatest similarity between what's predicted and what is the truth. And the cross entropy is vice versa. It's the loss or the log loss. And if we say ideally in perfect model should be 0. So in our data, we had the dye score of 0.83 and cross entropy of 0.16. So this is MRI. The yellow is the contour done by a radiation oncologist, and the red one is the contour done by our machine learning models. And nowadays, there are many artificial intelligence companies invested in creating a product that assists for organ at risk segmentations as well as contouring of the tumor. Each company had different characteristics and different product type. So also artificial intelligence to improve the precision of radiotherapy, we can do synthetic CT generations to enhance image guidance. So we can see the cone beam CT scan is usually low resolution, sometimes difficult to identify anatomy. However, we can create a synthetic CT scan from that, similar to some extent to the diagnostic quality. And that will really help and improve image guidance process in radiotherapy and improve the plan optimization as well. Also, from MRI, we can create a synthetic CT that we can spare the patient the hazards ionizing radiations, and then we can improve and plan optimize and then help the treatment. Using of these AI and radiation oncology definitely make our work more efficient, save costs, and make the productivity more. So also something we are proud in King Faisal is we're using the 3D printing technology that provide a personalized, efficient, and optimized radiotherapy treatment. And this we can use it during the simulation process, treatment session, to define the treatment zone to protect the organ at risk outside those zones. I will give you an example of a skin lymphoma case. In the past, we treated with a conventional workflow as shown above. This time-consuming, labor-intensive method, patients need to come in couple occasions to do the treatment process. Nowadays, with the 3D printing workflow in King Faisal, we can become more efficient. Patients usually come one time, and it's very quick visit, 5 minutes. And most of the process is digital, is accurate, and reproducible as well. So this is a case of a skin cancer at the nasal bridge area. It is BCC cancer, resected and then grafted. Unfortunately, patient had a positive deep margin. So this is critical area between the eye globes near the optic apparatus. It's really creating a challenge how we deliver radiotherapy. So we decided to use the 3D patient-specific device. We did 3D printing like eye goggles that will do shielding to the both eyes, as well as bolus effect to the nasal bridge area, and we're able to deliver electrons safely to this case. Other is using surface brachytherapy and 3D printing technique in post-mastectomy scar. So the picture on your left-hand side this is usually we do the electron treatment. Usually with electron in these cases will give you a non-uniform dose for tumor that's in curved surface with a lot of uncertainties. And also the chest wall usually is mobile structure during the breathing cycles, then will create a non-uniform dose distribution. However, with the brachytherapy treatment using the 3D printing technique, we are able to do a uniform dose distribution to this curved surface, as well as the quality of treatment is not being affected by patients' breathing cycles. These are the process. We do the digital processing, printing the material, patient do simulations, and then we deliver this brachytherapy. And then for treatment delivery, some of the work we try to improve the precision is using the brachytherapy. So brachytherapy is delivering radiation within the tumor, and we use the image guidance adaptive brachytherapy using the intracavitary applicator, usually for early stage cervical cancer. In locally advanced cervical cancer, we use the hybrid technology when we add interstitial needle to this intracavitary brachytherapy to enable dose escalation and to minimize the dose as much as we can to the normal surrounding tissue. I'll give you an example here. Is the pictures above is showing the partial utilization of the hybrid approach. You see the tumor on red. Okay, I don't know. Okay, so the tumor is on red. The lateral aspect of the tumor is not covered on that example, and we can see that on the axial CT scan. The red line represents the high dose radiation line. Lateral aspect of the tumor is not covered, as shown in the yellow, as well as the rectum had a great dose of spillage of high dose radiations. If we utilize the interstitial needle and the hybrid applicator, we can see down on the axial CT slice that the tumor well covered with the high dose radiation area, and we're able to spare the rectum. And we're proud of our gynae team in the last 3 years that they treated almost 900 patients with this. They did 2,000 implanted catheter and more than 1,100 implanted needles. So also we do have CyberKnife technology in the last 10 decades. This is unprecedented targeting accuracy. There's continual image guidance throughout the treatment, automatically track, detect, and correct for intrafractional movements. And this is the room of the CyberKnife. We can see the linear accelerator and robotic arm, and then we can see the image sources as well as the target software. So, and then in the past, we treat patients with the respiratory gating. That's during specific phase of breath cycle, we deliver radiation. Other method is ask patient to take a deep breathing and then hold and deliver. And then now with the CyberKnife technology, we dynamically track the target motion through the respiratory cycles. And with this, we significantly make smaller planning margin to maximize surrounding health tissue preservations. And proton, this is technology we are eagerly wanted and to have in Saudi Arabia. Why proton is because of the Bragg beak. You can see there is exquisite dose distribution. There is a potential for reduction in normal tissue doses. There is potential for escalation the dose, reduction in toxicity, improving quality of life, improve local control, and potentially improve in overall survival. There is possible biologic advantage with this technology as well. However, this beautiful dose distribution does not come without uncertainty, some of which are related to patients, some of which related to biology, physics related, machine and instrumentation related. And with the progression of radiotherapy technology, like this case example of esophageal cancer, what we treat in the 90s with 3D conformal or the 2000 IMRT and VMAT, and now the intensive modulated proton therapy, we can see the heart dose, the lung dose in this particular example, the liver dose is becoming lower and lower and lower. So this will really improve quality of life by reducing the side effect. And there is increased access worldwide to the proton therapy in North America, in Europe, in Asia as well. And then there is also a lot of new coming evidence with the benefit of the proton. I'm a head and neck radiation oncologist. Then the oropharyngeal cancer, for example, there is a clear reduction in the needing of the G-tube insertion. Hepatocellular carcinoma, maybe there is overall survival and different benefit with different tumor sites. However, there's obstacles for this proton radiotherapy, as there is limited number of proton therapy centers to publish their data, and there's the average time to publications. And there is varying definition of the medical necessity. And then, of course, the insurance company, medical policies as well. There is increased number of randomized studies. However, we still need more of the randomized study, photon versus proton. There's also barrier for the rapid proton therapy adoptions, large gantry design, the infrastructure requirement, the shielding requirement, etc. However, there is a collective industry development that better gantry design, better floor design, better vault design, and then the construction time become less and less. So, and then now that we have the compact unit, which may be the ideal situation in the future. Other new technology that we need to have in Saudi Arabia is the MR-Linac. So this is combining the MR technology as well as linear accelerator in one machine. And you can see clearly the tumor, you adapt in real time, you monitor the motion, and then you assess the response. And then this is have the state-of-art 1.5 Tesla MRI. You can have a real-time motion monitor. There is large imaging field. You can do also functional image to test the response. And then you can also treat in real-time motion monitored during the treatment. So you see the tumor clearly, you can monitor the motion, you adapt on real time, you treat accurately, and then you improve, you adapt depend on that. So with all the newer technology, drugs, immunotherapy, the aim and the hope is the same, to improve the survival of our patients, and that's what we see over the years for various cancers. And I think the future is bright to our field, oncology in general and radiation oncology in specific. I'll just tackle the artificial intelligence. I think it will do a lot of job beyond the auto-contouring. AI, I think, will play an increasingly important role for planning optimization, outcome prediction, and more personalized radiotherapy. Also the biologic guidance. So the continued development and integration of the biological imaging and biomarker will further personalize the radiotherapy. So this is my last slide. I think precision radiotherapy is key to maximize treatment effectiveness while minimizing the side effect. However, this is require a dedicated team expert from rad-onc, medical physicists, dosimetrists, therapists, and other essential healthcare professionals. And with that, I'd like to thank you for your time and for your listening. Thank you.
Thank you, Dr. Dahaim, for the excellent presentation and sharing your experience at King Faisal Special Hospital in Riyadh. It's my great pleasure again to introduce Dr. Jeff Bradley, and he will give us a talk about a clinical indication for proton therapy clinical trials and case example. Dr. Bradley, mic is yours.
Thank you. Thank you again. Hello. Thank you again for that kind introduction. Congratulations, Mohammed. That was an excellent update for radiation therapy. We've seen a tremendous amount of AI development in the last few years, and we certainly depend on that for our daily operations. So, excellent summary. I was asked to talk about clinical indications for proton therapy, clinical trials, and case examples. These are my disclosures again. Overview here is to understand the physical advantages of proton therapy, to understand the reasons to consider proton therapy, and to review a general approach and treatment implementation. So what is proton therapy? Conventional radiation therapy, which is X-rays, are on the left, and proton beam is on the right. You can look at the images below. Photons go all the way through the patient by design. Protons stop just beyond the target, so normal tissues beyond the target are not irradiated. So there's an advantage to protons there. This is an example of a sphenoid wing meningioma. What X-ray from a lateral field what the dose distribution looks like from a single lateral field and what the dose distribution looks like with proton therapy. If you had a patient with that, what would you prefer? Proton therapy, right? Because you're going to miss a lot of brain that's not treated at all. That's because of the physics of proton therapy. The pink is a photon depth dose curve where you reach a maximum depth around, for 6 MV, about 1.5 centimeters, for 10 MV, around 2 centimeters deep. But the dose goes all the way through the patient. You can see the depth in water on the x-axis versus the protons, which is the blue curve, stop just beyond the tumor. That's called a spread out Bragg peak. So proton therapy is selective. Many patients are successfully and appropriately treated with photon therapy, so we choose which patients receive proton radiation. The treatment of advanced and complex cancers is morbid, even with the most advanced forms of radiation therapy. Long-term after effects of treatment can significantly decrease their quality of life, and we want to offer protons to those we feel can improve, where we can improve their outcome, cure or toxicity. This is the same example of a sphenoid wing meningioma, IMRT on the left, protons on the right. What the radiation dose distribution down to a level of 2 gray is in the brain, protons versus photons. You can see we reduce the dose to normal tissue. There are 46 operating centers in the United States with 12 or 13 planned to be installed. So this is still not universally available, even in the United States. You have to live near one of these centers to have access to it. There are challenges to it, as you discussed: cost, resources, appropriate utilization, insurance, and there are potential benefits. Normal tissue sparing, which is decreased toxicity. That can lead to increasing the radiation dose. It may allow for treatment of tumors in locations not treatable with conventional radiation. A classic example would be reirradiation. Approximately 20% of cases treated at proton centers are reirradiation cases, like head and neck cancer or lung cancer, and tumors in complex locations. I have some examples of that. So the rationale is to treat patients who meet, at Penn, the rationale is to treat patients who meet at least one of the following criteria. The normal radiation reveals high rates of tumor control but a cost of significant toxicity, so we want to use for toxicity mitigation. Or when local control is unacceptably low with standard radiation, and we want to increase radiation dose and do so with protons. This is a classic example. You've probably all seen this, but today at Penn, we don't use photons for craniospinal radiation. Every patient get proton beam therapy, and the reasons are clear. You simply avoid all the target beyond the spine in a patient with, let's say, medulloblastoma for craniospinal radiation. Or, as I mentioned a couple of days ago, a new indication for leptomeningeal metastasis, craniospinal radiation for patients with leptomeningeal disease. Anal cancer, protons on the left, photons on the right. Lung cancer, protons on the left, photons on the right. You're getting significant amount of lung sparing and heart sparing in a case of locally advanced non-small cell. Another example of lung cancer and pencil beam, x-rays on the left, protons on the right. Another example of lung cancer, you can tell I treat lung cancer, right? Another cancer, lung cancer, in this case, significant heart sparing. We learned from RTOG 0617 how important it is to spare the heart with radiation. So we implemented dose volume constraints for heart. in all of our trials, and we use them in clinically all the time, and protons are a good way to miss the heart completely. Limited stage small cell lung cancer. The image on the lower right shows complete heart sparing. Looking at clinical evidence, this is a summary of level 1 trials involving 8,000 patients and over 17 major studies to be published regarding protons in the coming years. Looking at dates from 2024 through 2028. These are when they will report out, or an estimate of when they will report out. So we have a lot of data coming in terms of showing the benefit of protons in clinical trials. Hopefully some of these turn out positive, or most of these turn out positive. This is just the source data for those. It's hard to read, so I won't read them, but the source data for the trials in that table. But I'll show you the positive randomized trials favoring protons. Mohammed mentioned the oropharynx study by his mentor, Stephen Frank, that was presented at ASCO this past year. It was a non-inferiority study. At the time he presented it, it showed a progression-free survival benefit for patients with oropharyngeal cancer, head and neck. Since then, Steve tells me there's an overall survival benefit, and that looks like it's completely related to reduced toxicity, reduced hospital admissions, reduced feeding tubes. So you reduce toxicity. There's a study in leptomeningeal disease out of MD Anderson out of Memorial Sloan Kettering in New York, looking at craniospinal versus localized radiation for patients who are fit but have leptomeningeal metastases. Stephen Lin has an esophageal cancer study, and Dr. Chang has an early stage lung cancer study that so far have been published or reported in favor of protons over IMRT. There are some negative studies. Not all studies are positive. There's Dr. Liao with an older version of protons called passive scattering, which you can't even buy anymore, but that study was passive scattering, and there was no difference in radiation, whether given with protons or photons. This is commonly cited as a negative study. It's like it's old-fashioned proton beam. So they learned a lot. The second half of the study, patients benefited with protons. The first half, they did not. Overall, no benefit in the study. Glioblastoma was negative, and Jason Efstefau out of Boston reported at ASTRO early-stage prostate cancer, a quality of life study looking at bowel toxicity, was no difference between protons and photons. This is Stephen Frank's abstract for ASCO. I don't have his slides. 440 patients across 21 institutions. Took three years to accrue. They estimated a 3-year hazard ratio of 0.87. He reported IMPT was non-inferior to IMRT, but also had a progression-free survival benefit. This is the prostate study, which was negative, reported at ASTRO. This has been published. Patients were randomized, the protons versus photons, and you can see in terms of the primary endpoint on the upper right, quality of life, bowel toxicity, and biochemical failure-free was equivalent between the two arms. By the way, it's very difficult, more difficult for us to get insurance approval for prostate cancer in the United States. So it's only at Penn, it's only 10 or 15% of our volume. It's not, most of those patients refer themselves for protons, for radiation for prostate cancer. So I've shown you head and neck examples. Obviously, there's a lot of side effects and morbidity that comes with radiation therapy to the head and neck. You can see the list here. So the more you can spare that, the better. This is an example of pencil beam scanning versus protons versus photons, and you can see we spare the oral cavity on the left with protons better than we can spare it with photons. Contralateral submandibular gland sparing, protons on the left, IMRT on the right. parotid gland sparing, protons on the left, photons on the right. Oral cavity sparing. Now, protons have their challenges. They're technically more demanding. There are fewer centers, fewer experienced teams. It's geographically restricted. There's a high cost of investment. They're more resource intensive to deliver. We hire 2 physicists for every proton room compared to 1 physicist for a photon room. More expensive for our payers. There are challenges such as in-room imaging. I'll go ahead and say this. In-room imaging with proton machines lags behind what it is with photon machines. It's certainly not the MR images that you just showed. Proton images are not quite as good. They're improving, and different companies have different quality of in-room imaging available. We're starting to use dual energy CT in the treatment planning to reduce range uncertainty, which makes our margins tighter with proton beam. They're subject to changes while a patient's getting treated. If you see the image on the right, that patient has a pleural effusion. And because that's a different density than air in lung, that changes the dose distribution. So you have to pay attention each day to each day's imaging on the cone beam CT to make sure your target is the same and that everything in between where the beam enters the patient and your target is the same. If you have fluid there, it changes the dose distribution. And you're going to miss target in this case, but sometimes you'll give more dose to the spinal cord or more dose to the esophagus, and you need to pay attention to that. Roughly half of the time that we're treating, I use it for lung cancer, roughly half the time in patients, I need to do what's called an evaluation scan or a mid-treatment CT scan and replan the case because there's some anatomical change. This is an example of a case where the patient mid-treatment, it's a thymic carcinoma, but mid-treatment, the patient developed a pleural effusion, and that changed the beam angles that we needed to use to come at this tumor, so we did not put the beam through the pleural effusion. This is a patient I treated recently. She'd had prior radiation for a left breast cancer at an outside hospital, and you can see the thymic carcinoma there that existed where she was treated previously at the outside hospital with breast radiation. She was referred for protons because there would be overlap. And you can see the dose distribution on the left where we were able to avoid overlap over the treated breast. And in her case, mid-treatment, she developed, this is about halfway through treatment, I noticed that her tumor was shrinking, and so we replanned it. You can see the smaller target on the right compared to the left. I gave her, 66 gray, and she had about somewhere midway through treatment, she had a tumor response. So we were able to even make that overlap less midway through treatment. So in summary, protons have an advantage of reducing dose to normal tissues. We think of the tumor cell kill as the same between protons and photons. Thus, we can, by missing target or missing tissues, normal tissues, we can increase the radiation dose to the target, or we can even use protons to hypofractionate, reduce the number of visits the patient needs. Demonstrated settings where there are advantages of protons include pediatric cancers, tumors around the base of skull, eyes, sinuses, head and neck, reducing normal liver dose, so we like to use it for liver tumors, reducing heart dose, I like to use it as I showed for lung cancer, and reducing bowel dose. And there are multiple clinical trials to be reported in the near future, and I showed you a positive trial, and I showed you a negative trial. As we go, we learn. Thank you again.
Thank you, Dr. Bradley, for the excellent overview of proton therapy. I will ask you to join us in the podium for the question, and Dr. Dhaim as well. And the floor is open for questions. Prof. Bahadur, Mike.
Thank you so much, this very educational presentation. My question is about the proton therapy. It seems from the presentation the main advantage is in reducing the side effect of the surrounding structure. But the endpoints in the trials, it seems they are looking for survival, disease-free survival, local control. So it's not surprisingly it will be a negative trials. Maybe if the aim of the trial is measuring the toxicity, what do you think?
I have a lot of comments about that. That's a very good point. The oropharyngeal trial, there's a survival benefit because you're reducing toxicity. That's why there's a survival benefit. Within the NCI mechanism in the United States, for me to pitch a trial through our cooperative group mechanism for them to submit it, in order to be reviewed, I need to either have an endpoint of overall survival or progression-free survival. So that's one obstacle. It's hard, we wouldn't be able to get a proton trial through with a toxicity primary outcome. And radiotherapy companies don't sponsor trials. So we're kind of in a box where we're trying to show benefit by reducing toxicity. So that is a major problem. We've had meetings amongst proton users across the world about new endpoints, using toxicity endpoints, or combining toxicity endpoints with let's say, progression-free survival endpoints, getting creative with our next wave of trials. But as you can see, I showed there's a number of trials that are going to come across the world that are going to come out over the next 3 to 4 years that are already set in place. But I agree with you. The benefit is in the toxicity, reduced toxicity.
Thank you, Professor. One more question. In your presentation 2 days ago, you said that in your center there is a dedicated educational program for proton for physics, therapists, and physicians. If you can highlight on this, please, for those who missed that presentation.
Sure, thank you for bringing that up again. The proton community across the world is a small community. You showed, how many proton centers, and that's a small community, so we need to learn from each other. So most centers, and I started a center in 2013 in St. Louis. When I was there, we didn't know anything about protons. We needed an education, and we trained ourselves because there was no educational course. But at Penn, we have a course that's three components. Video modules that you can look at on your own at home. The modules are for physicians, physicists, therapists, dosimetrists. Then we invite teams to come on site at University of Pennsylvania, and they could be there for a week or 2 weeks or a month, however long they want to be there. We set up a schedule for them where they spend time with each portion of the workflow that the patient goes through, and we tailor it to your vocation, whether you're a physician or a physicist, et cetera. And then afterwards, we have a strong relationship because you spent time with us. So it's common we get called to look at a difficult case and offer advice, or let's say a physicist needs advice about commissioning or checking a plan. So we're proud of that. We've trained 74 centers. We've trained 1,500 people online, and like 375 people have come through our program since 2017. Thank you for asking about that.
Excellent.
Thank you.
Also, I would like to add, Prof, is that I spend with Dr. Liao sometimes. I discuss with her the negative trial. She attributed that also the learning of her, the team, the physics, the dosimetry, the physicians, because the proton was new at that time, though it's also passive scatter technique as well, maybe other contributions. But she did a midterm analysis of the trial before, where the team's still learning, get the momentum together, and then after, there's improvement definitely after halfway through the clinical trial.
Yes, that's an excellent point. I think that's the most important figure in that manuscript. When they divided the timeline in half and they looked before
Yes.
and after. And I was on a team that went to MD Anderson to look at the patients with complications, to make sure the scoring was right, because one of the endpoints was radiation pneumonitis, and we looked at the volumes. And one of the things they changed after midpoint, this is again with passive scattering technique,
Yes.
which we don't even have today, so it's, you can't, but they excluded patients at the midpoint, they excluded patients with lymph nodes on the contralateral side of the chest. That was the main change.
May I ask you, Prof. Bradley, I need your explanation and theory why a Pacific 2 negative trial. Is it only toxicity, or you have a different theory why concurrent durvalumab is not as good as adjuvant durvalumab?
So I showed 4 studies
Yes.
where concurrent immunotherapy and radiation therapy, that the addition of them concurrently did not show a benefit. And one of those was the first reported, I reported it at ELCC in 2024, last March. That was a surprise. We all thought it was going to be positive. You're asking about toxicity. Yes, the patients had more toxicity. They got less doses of immunotherapy. The curves did not separate early like they did in Pacific. So that showed, and the patients, the physicians stopped their immunotherapy. I think that's part of it. We've also have the database to look at this EDIC, estimated dose to immune cells. We collected radiotherapy plans for that case using a third-party company. The name of the company is Radiologica. I got AstraZeneca to pay for that. And so we have all the radiation volumes, the targets, so we can comb through those data sets to understand it better, and we are starting to look at that. Thank you. We submitted that paper to JCO this week. I hope it gets published there.
Okay. Looking forward.
My question related to the first talk, combination of immunotherapy and radiation therapy. I think you answered part of it. How do you explain the difference outcome between the first trial in 2017 and the other 4 trials? Is it modification in the dose of radiation? I think all those immunotherapy is almost the same. And even Durva, when it is used with radiation therapy, the later trial, we are getting negative or at least equal result. Do you have explanation for that?
I can think of 2. One is you're irradiating lymphocytes and you're killing lymphocytes while you're trying to get the immunotherapy to, bring T cells to the tumor. So I think they're working against each other. We did another trial in oligometastatic disease where we gave, it was randomized phase 2-3 trials called LU002, and it was reported at ASCO this past year, and it was a negative study. We gave systemic patients with metastatic disease, 5 or fewer metastases. They got immunotherapy or chemotherapy and or immunotherapy plus or minus local radiation therapy. And it was a negative study, and in that case, patients simply got fewer courses of immunotherapy. So I think part of the answer is they're getting less immunotherapy. So the idea of enhancing, letting them get their immunotherapy and enhancing the effect of immunotherapy is something to carry forward from those studies. I hope I answered your question.
So, Prof. Bradley, radiation-induced lymphopenia is quite interesting topic. So it's proven, I'm not sure proven, but in lung cancer, yes, esophageal cancer, but other type of cancer is not well understood. So you still believe that lymphocyte is the key by radiating the lymph nodes might deteriorate. Do we have clear evidence or just this speculation?
No clear evidence. I'm looking, the edict is sort of a surrogate for that. Looking at, in small cell lung cancer, for example, in the small cell study, small cell patients have large central tumor volumes. We can look at tumor volume and tie it to tumor volume. That's a mechanism of trying to figure that out. But right now, it's just I'm not the only one that thinks that, but it's what I think, yes.
I see.
Thank you for all speakers. It was excellent talk. So my question to you, Dr. Bradley, regarding the effective immune therapy and radiotherapy and the abscopal effect. So my question is, we do have the data regarding Pacific, and now we do also the Adriatic study confirming the role of radiotherapy plus immunotherapy. So do we have any data regarding the effect of the dose intensity or the fractionation to enhance this effect? Specifically in the Pacific, they pointed that 60 gray, it's the usual dose, and when we de-escalate, it was not the same effect. Thank you.
I believe the question was optimizing radiation dose related to giving immunotherapy. And I don't really know the answer to that. You know, radiation dose in lung cancer, we set, those are using 60 gray because of a trial we did within the RTUG called 0617, which randomized 60 gray versus 74 gray and showed that patients with 74 gray had worse survival. I think that's related to heart dose. So 60 gray, all the trials use 60 gray or up to 66 gray. And we haven't asked the question, can we change the radiation dose in the era of immunotherapy? I showed you an example of some ideas to only treat the primary tumor and miss the lymph nodes. We've got a trial within NRG right now where we're giving stereotactic radiation in 3 to 5 fractions for a peripheral primary, followed immediately by 60 gray and 2 gray fractions to the lymph nodes in patients, and then they get immunotherapy after. So we are starting to ask questions about dose, but really that's an unexplored area.
Dr. Bradley, do you think you have a good long experience, about 15 years, for the proton therapy? Do you show that proton therapy can enhance the abscopal effect more than the photon?
The question, I think, maybe your mic wasn't working, can protons enhance the abscopal effect versus photons? I don't know. I think that's a great question. I don't know the answer to that. I've pitched ideas to pharmaceutical companies asking that question, pharmaceutical companies with immunotherapy drugs. I haven't got anyone to bite on that yet, but I think that's a great question to ask. If you had a proton machine, could you exploit that effect? I don't know the answer. Good question.
And Prof. Bradley, and regarding the adding durvalumab to early stage lung cancer, I see that you showed us the data from phase 2 trial, right? Where do you see the future? Do you think we will add durvalumab despite the toxicity that we have?
So we're all very excited about those iSaber results because it shows, the local control with stereotactic radiation for early stage lung cancer is 90 to 95%. But those patients fail in the lymph nodes and they develop distant metastasis. So you saw the curves. I think the number was 77% event-free survival. So that's very exciting. And then Merck comes out with their press release that's a negative study, to our surprise. And then that SWOG effort where you give immunotherapy up front followed by radiation therapy was negative because I think you're irradiating, you stimulated the immune system, and now you brought all the T cells to the tumor, and now you're killing them with radiation. And then we have this 650 patient trial, Pacific 4, waiting to read out. It will read out in about a year. So I hope it's positive.
Thank you. Last question or?
Dr. Bradley, thank you very much for your nice presentation, Dr. Muhammad too. My question about the immunotherapy part. We know most of the patients nowadays are getting benefit from the immunotherapy either in the unresected lung cancer or even in the early perioperatively. Do you think that adopted and the guidance of the immunotherapy with repeated biopsy in the middle of the course of the radiotherapy to see whom are getting changes in the microenvironment, I mean PDL testing getting rich, so those may benefit more and we can save some money from this?
I can't quite interpret your question. Can you?
My idea about the interval biopsy dynamically guiding the immunotherapy part of the treatment by repeating the biopsy at the middle of the course of radiotherapy to know if we have changes in the BDL status in the microenvironment. So accordingly, we can save some money from those who are not getting rich BDL testing and still desert environment. Do you think this can be adopted, or our trials are there?
I think that's a good idea. You're asking for a biopsy, another biopsy mid-treatment. I think that's a good idea. You'd have to select the patients to have tumors that are biopsyable, but I think that's a nice strategy to pursue.
Okay, I think by this we'll conclude the first session. I would like to thank Dr. Bradley, Dr. Dahaim, and my colleague, Dr. Muhammad. And by this we'll conclude the first session, and maybe I'll leave the mic to the coordinator. Thank you. Thank you very much.
Thank you, everyone. We will go for a coffee break for 20 minutes. We'll be back at 9:40. Hall A will be for thoracic oncology. Hall B for lymphoma and CAR T-cell. Hall C for nursing. Thank you.
Assalamu alaikum. Welcome back to the hematology session. So we'll go ahead and get started with this session about new horizons in CAR T-cell therapy. I have on the podium Dr. Al-Jurf and Dr. Mar'i will be moderating this session along with me, and we have 3 speakers for this session. We start with Dr. Najah. Dr. Najah is a lymphoma expert. She's a consultant at King Faisal Specialist Hospital, Medina branch. She joined from UK. She has an extensive background in lymphoma management and the clinical trials. She will talk to us about advancement in relapsed refractory diffuse large B-cell lymphoma management. Dr. Najah, the floor is yours.
Thank you very much. Assalamu alaikum. Good morning, everyone. So I recently joined King Faisal Medina. I had the privilege of seeing the changes in the management of relapsed refractory diffuse large B-cell lymphoma in the last couple of years. And it was very nice to see some of the drugs that we're trialing making their way into our clinics. So to start with, these are my disclosures. So I was given 20 minutes to talk to you about the changes in management in relapsed refractory DLBCL, which I don't think I can cover a lot of topics. So what I thought I will do over the next 20 minutes is just to talk to you about some of the points I will be thinking about if I'm seeing a patient in my clinic who's unfortunately having a relapsed or refractory disease. And so I've listed some of these points here. So I'll be thinking about how are the changes in the first-line management are impacting our treatment options for relapsed refractory disease. I'll be thinking what I have available to use for my patients in my area and how to optimally sequence these available therapies, but also how to choose the right treatment for the right patient. We know some of these drugs are quite challenging to give, so I'll be thinking about how I can effectively and safely deliver these therapies. I'm very interested in the long-term follow-up data for these treatments and the quality of life of patients receiving these therapies. And as a clinical trialist, I'll always be thinking about how are these changes are going to impact the future designs of our clinical trials, and also more importantly, what questions we should be asking in our clinical trials. So as a hematology registrar, I used to memorize this paragraph out of the BSH guidelines. This was published in 2016, so I used to talk to my patients about R-CHOP, and then I'll be talking to them about there is a 20 to 30% chance that the disease will come back after treatment, but there's also a 10 to 15% chance that the disease might not respond to R-CHOP. And we all know these patients had dismal outcomes. So we know the outcome for patients with DLBCL has changed in the last couple of years. Probably the biggest change in the 2000s was the introduction of rituximab as a standard of care with chemotherapy. We also had the publication of the PALMA trial, which showed that by giving patients high-dose chemotherapy and doing autologous stem cell transplant as consolidation improved the patients with relapsed and refractory disease. But over the last 5-6 years, we had a number of drugs coming through, and we now use them in our clinics. So if I'm sitting in the clinic with a patient who's unfortunately had a relapsed or refractory disease, what I'll be thinking about and how would I talk them through the treatment options? And for me, there are 3 important factors. A, the time of relapse. B, their fitness and their comorbidities. And C, what do they have so far? And more importantly, what do I have available in my clinics? So to start with the left-hand side of this flowchart, if I'm seeing a patient who's relapsing within 1 year, who are fit enough, I'll probably be offering them CAR T cell therapy as a second-line treatment. If they respond, well and good. If they don't, then this is when I will move to the box at the bottom. And we have a number of therapies. And at the moment, we don't really have data to support the use of one over the other, but I'll probably be thinking more of using a bispecific antibody for this patient as a third-line therapy. But I do have other options. So we'll have Pola-BR, we have Tafalan, we have Lonca, which I'll be talking about in a bit more details later on. We can use immunochemotherapy, but we know these patients don't do well with immunochemotherapy at this stage. And more importantly, we'll have options of clinical trials. If my patient, however, is not fit enough to receive the CAR-T, or if this is not available, then I'll probably be moving to those options a bit earlier. And for me, the box in the middle and the box in the bottom could be interchangeable depending on the availability of treatments and what's been approved for me to use. However, if my patient is relapsing with more than 1 year after completion treatment, I'll be thinking about autologous stem cell transplant because as approval stands at the moment, they're not eligible for CAR T. So I'll be offering, if they are fit enough, I'll be offering them salvage chemotherapy. If they achieve a response, then they will move into autologous stem cell transplant. Patients who are not responding or have not achieved a good response will move into CAR T at the third-line therapy. If they relapse further, then they move into the options at the bottom. The patients who are not fit for autologous stem cell transplant will be moving into those options a bit earlier. So what would I be thinking about first-line management and its impact on treatment or refractory disease? So for me, there are 2 key points. We know now we have treatment options available for us to use in the first-line setting. The best example is Pola-R-CHP, following the publication of the POLARIX trial. And we know a lot of countries around the world implemented Pola-R-CHP as the first-line treatment. Why is that important? Because we had the publication of this trial years before Pola-R-CHP was available. And it showed the addition of polatuzumab to bendamustine rituximab improved the outcome. So Pola-BR became a very important treatment option for our patients in the relapsing refractory setting. More importantly, it became a very good option for bridging for CAR T. And I personally liked using Pola-BR. It's a treatment that's easy to use. It has very manageable side effects profile. But now we will have patients who've received Pola-BR, Pola-R-CHP in the first-line setting. And as far as I know, we still don't have data to support that if we challenge these patients again with Pola, they will respond. And I think this story will keep repeating itself with more treatment moving into earlier use in the treatment pathway. The second important point is we all know DLBCL is not one disease. Professor Davis gave an excellent talk yesterday about the challenging biology of DLBCL, and the WHO classification recognized the importance of genetic and molecular data. And I've seen a lot of trial proposals recently, and almost in all of them, they incorporated circulating DNA as an exploratory test point because we know this is becoming very important. So this has the potential to actually for us to use personalized medicine in the future, but also more importantly, we might be able to identify patients who has a higher risk of relapse, and in that case, we might be using a different approach. So what do we have available to use at the moment? So of course, the bigger player in the field at the moment is CAR T. And I know there are a lot of talks about CAR T in this session, so I'm not going to go into details about CAR T. But if I'm sitting with my patient in the clinic and I'm offering them CAR T, what will I be thinking about? So the first bubble in the left is why I'm offering them CAR T. We know the data for CAR T is mature. We now have 5 years follow-up in the ZUMA-1 trial. We also know there's a wealth of information coming from real-world data, which proving to be very useful for us and providing us with more information. But I think more importantly for me is we've become very comfortable and very confident talking to our patients about CAR T. So we've been using CAR T in Cardiff where I worked before for the last 5 years. So we know what happens with these patients, and I can talk to my patients about the journey through the CAR T from A to Z. We know we have patients on long-term follow-up in our clinic, so we become more experienced in managing those patients. But we know it's not a very easy treatment, and you still have a lot of restrictions. So the bubble on the right shows some of these restrictions. It is an expensive treatment, and it's still a treatment that we cannot give very easily, so it's quite complex to deliver these treatments. And that's very likely, that's why some of these treatments will remain in the super tertiary centers, and it's will likely going to stay there for a while before they move into to other hospitals. And if anyone who's managed CAR T patients know there is a gap where you have to keep your patients well and you have to keep their disease under control, so vein-to-vein time, and this can sometimes be quite challenging. We also know it doesn't work for all the patients, and despite the improvement in managing in ICANS and the CRS, I still talk to my patients about they might need to take the trip to ICU if they become unwell. And there's a lot of strategies that in trying to improve some of these restrictions. And for me, that we're still talking about trying to deliver some of the more effective regimens, and there's a lot of trials and research going in to try to improve on these restrictions. The next bigger player in the field are the bispecific antibodies. So we've had CAR T in the UK, and we've learned how to manage it, and then we were told, now we're going to have the bispecific antibodies. So we all took a deep breath and thought, okay, here we go again. We'll have to try this again. But we actually were very pleasantly surprised when we started using the bispecific antibodies in our clinics and in the clinical trials, because now we had a treatment that you can pick off the shelf. You can give it to your patient without any delays. It has a very manageable toxicity profile, so we don't see the sort of severe CRS and neurotoxicity. Yes, a lot of the patients might get a grade 1 or grade 2, but very rarely your patient will need to take that trip to the ICU. And it's less expensive, and it's very deliverable, so it can be given in a lot of clinics, and actually your patients does not have to take that trip to the bigger centers to have that treatment. And people are even talking about delivering bispecific antibodies in an outpatient setting. But there are still important questions for me when I look at bispecific antibodies. Probably the most important is, what do we do with patients who are responding? And a lot of my patients had chemoimmunotherapy, had CAR-T, and then they moved into the bispecific at the third line, and they are responding. And then we sit in our MDT discussing, should I consolidate with an allo, should I stop? And at the moment, we still don't have enough data to support that use. And I think the other important things, we know these drugs have been trialed as a single agent, but it's very likely they're going to be more effective with using them as a combination therapy. One of these combinations, which I think is quite interesting, is the addition of glofitamab to GemOx. This is being presented in EHA last year, and is also being published in the Lancet Oncology recently. And it showed with the addition of glofitamab to GemOx, you get really good and durable responses. However, the data is still very early, and they've presented 20-month follow-up. But I think it's one of these combinations will have some role in the next sort of couple of years, and it's very likely we're going to see more of these combinations coming through and being used earlier in the treatment pathway. Another combination is tafasitamab plus lenalidomide. So this was published a couple of years ago, showed quite a reasonable response, but for me, when I look at the data, the trial did not include some of the challenging patients I would see in my clinic, so it did not really include the double-hit or triple-hit lymphoma patients. It did not really include patients who've had an early relapse or progression of their disease within 12 months. But it is a combination that's available. I don't personally have experience with using it because it was not approved by NICE for us to use in the UK, but is available in some parts of the world. Okay, so in the next couple of minutes, I would like to talk to you about loncastuximab. I think this is a drug that's been overshadowed by its big brothers, but it might have a role in the next couple of years for us to use. So what is loncastuximab? Loncastuximab is an antibody drug conjugate. So it actually binds into the cell with CD19. It has attached to it a cytotoxic, BPDD, which is slightly different from what we've used with drugs like polatuzumab and brentuximab. The drug gets internalized, and then it got released into the cells, and it causes cytotoxicity by causing cytotoxic DNA cross-linkage, moving the cells to go into apoptosis. So the drugs was trialed in the LOTUS-2 trial, so this was a single-arm phase 2 study. It recruited 145 patients from around the world, and it recruited patients with a relapsed refractory disease, so patients had to have 2 or more lines of therapy. The drug is given intravenously of a 30-minute infusion and is given in 21 cycles. So in the trials, the first 2 cycles, the patients had a slightly higher dose at 150 micrograms per kilogram, and then that was downgraded to 75 micrograms per kilogram from cycle 3 onwards. Patient received a total of 12 months of treatment. However, patients benefiting from the treatment were actually eligible to stay on the treatment until disease progression. So the inclusion and exclusion criteria, I would think, is very standard for a trial for relapse refractory disease. Probably the key point in the inclusion criteria is the patients had to have a biopsy-proven CD19 expression, which is quite logical because the patients are going to receive a CD19-directed therapy. In the exclusion criteria, they excluded patients with active CNS disease because Lonca does not have good activity or penetration to the CNS. And halfway through the trial, they also had an amendment to exclude patients with very bulky disease, more than 10 centimeters. And in terms of the patient characteristics, when I look at this, there are some key points. So if you look at the median age, it included some of our older patients, so 66 years old, which I think is quite important. It also included patients with a challenging disease, so such as the double and triple hit lymphoma patients. And also more importantly, they did actually include some of the patients who had prior CAR-T therapy. The numbers were very small, but you have to remember this trial was recruiting in 2018, 2019, before we had the wide use of CAR-T therapy. But nevertheless, they did include these patients. So what's the efficacy? So they had an overall response of around 50%. with 24% of patients achieving a complete response and 24% achieving a partial response. And the median time to first response was 41 days, which is very typical for these drugs that sort of utilize the immune system. The median duration of response for the 70 patients who responded was about 13.4 months, and the median duration of response for the patient who had a CR was not reached, and patients who had achieved a PR was 5.7 months. The median PFS was 4.9 months, and the median overall survival was 9.5 months. They also did this interesting analysis to look at the overall response in the different patient subgroups, and they showed it actually effective and efficient in all of these subgroups with no big differences between the different subgroups. So they also had these patients who had CAR-T. So again, the numbers are quite small, so I don't think we can draw very firm conclusions based on that. But they did show in half of the patients, they did have a response, with 2 patients achieving a complete response and 4 patients achieving a partial response. So data is very small, but it does show the potential if the patients continue to express CD19 or in their lymphoma cells, they could potentially respond to further CD19 therapy. And they also had included patients, so data for patients who went in to have further treatment. And for us, that's quite important. So again, numbers are small, but they also showed there's like 12 patients who went in to receive autologous stem cell transplant. So this potentially has shown we can use these drugs as a bridging therapy for some of these data. And also further patients, so further patients went into half CAR-T, again, numbers are small, but half of the patients had a complete response, again, showing a potential that as long as these patients continue to express CD19, they might benefit from CAR-T. And in this box plot, it just shows the expression of the level of expression of CD19. And actually what they've shown, even patients who had a low level of CD19 expression actually had a good response, and there was a massive difference between the level of expression between patients. So I'm very interested in side effects because this is what I'll be talking to my patients about. And if you look at the side effects profile for the drugs, again, quite standard for a lot of our treatments, but there are some side effects which are of special interest and slightly unique for the use of Lonca. And these were the peripheral edema, the pleural effusions, and the photosensitivity reactions. And halfway through the trial, they had a protocol amendment to include dexamethasone and spironolactone as a standard pre-treatment medications. And in general, all investigators thought these side effects were actually manageable and reversible in a lot of cases. There were also some side effects which were primarily lab side effects, particularly hematological toxicity, which we expect with patients receiving treatment in the third-line setting. But in general, they were very manageable. They've also noticed an increase in gamma GT in a lot of patients, but again, that was reversible and was not affecting the liver synthetic function. This is also quite important for me because if you look at this, it also shows the different side effects according to patient age group. And this trial included patients, so almost half of the patients were above the age of 65. And what I've shown, there is no increased toxicity observed in older patients compared with younger patients. So in conclusion, the LOTUS trial recruited patients who had 2 or more lines of treatment. Loncostimab was used at 3 weekly cycles. It showed a good response with these patients, including patients who've had exposure to CAR-T. The side effects profile was very manageable, and also we know some of these patients went in to have further lines of treatment. So we're running out of time, but I just wanted to share with you a further trial including Lonca. So this is now a phase 3 randomized trial, and obviously in a lot of these treatments, the next step is to try to combine them with other agents. So this trial is combining rituximab with Lonca and comparing it to R-GemOx. And we now have some results from the safety run of 20 patients. They managed to recruit 330 patients, and I understand the data is going to be presented later this year. So this is the trial design. And in the 20 patients, again, I would like to point out the age of the patients. So the median age in this trial was 74.5. And they showed a really good response. So almost 80% of patients had some response, an overall response. But again, this is the safety run, and we have to wait for the full data to be presented. There was no new signals in terms of toxicity compared to the other trials that were done before. So I think it'll be interesting data that we will hopefully see the results at the end of the year. And so hopefully, I've managed to discuss some of these points I've listed at the beginning, and in the sort of the next 2 minutes, I just want to present this case which highlights some of these important points I've discussed, listed earlier. So this is a patient I treated in Cardiff. He is a 50 years old taxi driver. He was diagnosed with stage 4 DLBCL with a really funny pattern of his disease. So he had a lot of extranodal disease. He was very fit and well, and at that point, we did not have Pola-R-CHP approved in the UK, so I treated him with R-CHOP, and he had an excellent response, and his end of treatment PET scan showed a complete metabolic response. However, he contacted me 4 months later, and he's one of those patients who are very sensible. So when they call you and say, I'm not well, you take it seriously. So he said his B symptoms were recurring, and unfortunately, when I saw him in clinic, I diagnosed him with an extensive relapse, particularly an extensive abdominal disease. At this point, CAR-T, the second line, was available in the UK, so we arranged for him to have his leukapheresis, and I've used Pola-BR as a bridging because he was not exposed to polatuzumab. And again, he had a very excellent response, so he clearly still had a chemosensitive disease. And we then moved into CAR-T, and he had a very uneventful hospital stay. A bit of tocilizumab and a bit of steroids, but nothing major. And we discharged him home, and I was following up in the clinic. His month 1 PET scan showed a complete response, and just before we did his month 3 PET scan, he started coming to our day units almost on a weekly basis with really significant and recurrent chest infections. So he will call and he will bring him in, we'll do his observation, no fever, CRP low, but then by the time he will get his results back, he's having either flu A or flu B, RSV, and he also continued to grow Pseudomonas in his sputum. So we've done multiple investigations. He had quite a horrible looking CT scan at some point. We did a bronchoscopy. Again, we grew a range of organisms in the samples, and we managed to treat them, but they just kept coming back to the point that I had to arrange for him to be seen in our day unit on a weekly basis. And at that point, he was on cotrimoxazole, acyclovir, IVIG, because his IgG levels were a bit low, and he also was in a range of asthma sort of medication because my respiratory colleagues thought might be a late onset asthma. But he was still having to come on a weekly basis to be reviewed. So he wanted to go back to work because he was supporting a young family, but we couldn't really let him go a couple of weeks without being seen in a hospital. So despite him having a very successful treatment, he was actually now dealing with the side effects of the treatment. And what I hope is at some point his immune system will kick back in and he will be able to fight this infection in a more effective way. And I'm finishing exactly on time. So thank you very much.
Thank you. Thank you, Dr. Najah, for sticking to the 20 minutes. So we'll take questions at the end. We have a little change in the schedule. So we have Dr. Farhatullah Sayyid. He's virtual. He will join virtual. Then we'll go and start with Dr. Wella after Dr. Farhatullah. So Dr. Farhatullah Sayyid is a senior scientist, cellular therapy scientist at King Faisal Specialist Hospital and Research Center in Riyadh. He has done a lot of work on CAR T-cell production and point-of-care CAR T-cell production in our center and abroad before joining. So he will talk to us about point-of-care manufacturing and advanced cell and gene therapies at King Faisal Specialist Hospital. He will be joining virtually. Dr. Farhatullah.
Good morning. Good morning. Can you hear me?
Yes, clear.
Yeah. Thank you so much, Dr. Riyad, and I really appreciate. Thank you for organizing committee to inviting me, and apologies I couldn't join in person. Let me know if you can see my slides.
Yes, we do.
So just want to give some overview, introduction, and I want to take through some kind of, what we have done previously in terms of autologous CAR T cells and allogenic CAR T cells. Then I will share our thoughts and our progress in point of care manufacturing of CAR T cells at King Faisal Hospital. And then I will try to show some of the, R&D early pipeline, what we are trying to achieve in terms of cell and gene therapy at King Faisal Hospital. For the sake of time, I'm going to focus on CAR T cells, even though we are also trying to do some gene therapy. but we'll do only CAR Ts at the moment. So if you look at the current trend and market, there are a lot of investments happening in the cell and gene therapy due to, exciting time and exciting results. Similarly, what we are trying to achieve in King Faisal is we have a lot of different patient burden, and these are the, extrapolated patient numbers by 2030, what the patients can be eligible for cell and gene therapy. And we are trying to achieve this by treating these patients, or at least so, taking these patients to approach for the cell and gene therapy to prolong their lifespan. So compared to any other country, I believe Saudi Arabia has a more advantage to utilize these cell and gene therapy due to large number of patients. Okay, so with that objectives, the vision of King Faisal is to produce these kind of medicines at reduced cost and potent therapies, and reducing the manufacturing time so that patient access will be easy, not needed to wait longer time periods, and that is one of the challenge we are facing at the moment. And not only that, improved product quality and making them very potent cells and naive CAR T cells where we can give the patients in the body to expand the cells itself using the patient body. So these are our main visions for developing cell and gene therapy, mainly CAR T cells. So I want to just give a brief overview of, I'm sure everybody knows what is CAR T cells. It's a chimeric antigen receptor T cells, which will be, chemically synthesized a molecule and introduced into the cells using either viral vectors or non-viral vectors. Now we are using multiple ways of delivering these CARs. The advantage of these CARs is they are they do not need HLA mapping, HLA recognition, and you can use this chimeric antigen for various targets, not only proteins, carbohydrates, and glycoproteins. So based on the structure, based on the signaling domains, we have number of generation of CARs, first generation, second, and third. Now we have almost 6 generations. So these chimeric antigen receptors are very successful in liquid tumors, and we still have a lot of work to do for solid tumors due to various reasons we will discuss in our slides later. So I will start with our experience, how we started CAR T cells in the UK. This is one of the clinical trial which we were using on Prodigy Miltani system. This is one of the interesting trial because what we used here is DLI cells from the donor match, relapse patients. So we use the DLI to express CAR T cells and then infuse the cells in the dose escalation study. This was started in 2014. This was the first in human clinical trial on Prodigy. And successfully we treated 12 patients. So it's like a bridge between allogenic and autologous CAR T cells, where I have been exposed to Clinimax Prodigy to start this clinical trial in 2014. That was a very fascinating experience to see how we can use these cells to treat the CD19 indications. And then we also moved on to other clinical trial. Both of these were for adult patients. So other clinical trial I was doing with Martin Fule, Claire Rodi, and Carl Peck for ALCAR19, which is now I was very fortunate to work on this project at UCL Ghosh, where it's now approved by FDA. It's called OBCL1, Auto1 or OBCL1, and it was different CAR compared to all we are using in ISCART and Kimbria. ISCAR is a off-rate CAT CAR. The short period of binding affinity of the CAR makes this product very unique compared to all approved products. So I think in last year it's approved now for the FDA. So this was our experience with the autologous CAR T cells, but we wanted to move on to see how we can generate CAR T cells for pediatric patients. The reason for that, because the pediatric patients had a very difficult to get the starting material, and very poor starting material after multiple relapses and multiple chemotherapies. So we have to think something else out of the box. So we came up with the idea of how can we make this CAR T cells allogenic. So to make the allogenic CAR T cells, we had to use molecular scissors to remove a couple of alloreactive molecules such as TCR and for GVHD and allorejection MSC molecules and some other molecules which we were thinking to use for other purposes. So with that intention in mind, we first started to use allogenic CAR T cells um, from selectors. So selectors came to us when we were developing this platform with their reagents like talents to utilize these talents with the conjunction of CAR expression. So we use these talents to knock out TCR, and we also knocked out CD52. The reason for that is to alemtuzumab using as a chemo depletion. So we produced this cell successfully. The procedure was very laborious in that time because we have to knock out first TCR, then grow the cell slowly, then knock out CD52, and then grow the cells slowly, and then transduce the cells. So these multiple ways we have to manage the cells, prolonging and without exhaustion. And the whole procedure was 7 days, and successfully we managed to produce these cells first time in the UK and in the world. And after that, once we had these cells ready in the tank, in a liquid nitrogen tank, we had a patient which is 11-year-old, Laila, and another patient, 16-year-old. They do not have any options for other treatments, so we have utilized this CAR T and compassionate use. So successfully we treated them for using this alloCAR, and that was the first news came up in the media where first CAR T cells, allogenic CAR T cells used in the world to treat BLL for the children's. And after that, we treated 3 more patients, and totally 5 patients we treated successfully, and they are completely in remission now. So once we finished the trial, treatments, the selectors have taken over the trial, and they have started their UCAR19 large-scale trial. But it was not, happy for us because we wanted to start our own something, similar kind of a clinical trial. So we had to come up with a different idea. We had to go back to our drawing board and see how we can utilize these CRISPR-Cas9 or other reagents to make these allogenic CAR T cells. So that time, selectors have patented all the equipments and reagents. So we had to use CRISPR, and we had to use Prodigy. I was already trained in Prodigy, and we have to use some other equipment to knock out this molecule because the equipment we were using for selector trials, BTX, that was also patented by selectors. So we have to use this Lonza machine to knock out these alloreactive molecules. And then we started our own vector development combined with CRISPR-Cas to knock out these molecules. Not only that, we use 2 different starting materials such as healthy PBMCs and cord blood CD62L selection, because these are the naive T cells coming from cord blood, so it is very advantageous. So for successfully we developed this product, and we were more optimistic because the product was very pure in terms of TCR positive cells, very lower than 1% TCR positive cells we had, because that will be most important for GVHD. Not only that, we also successfully produced using umbilical cord blood. Now this is published, the clinical trials are going on. The advantage of allogenic CAR T cells is with one batch of one bank, you can at least give 10 to 15 patients. So that way you reduce a lot of cost. So that was the stepping stone for us. Not only that, what we wanted to see is how we can move forward using based on the knowledge we have using the CRISPR-Cas. So we use allogenic CAR T cells for TALL. This is the first in world using the base editors to knock out alloreactive molecules. Plus, we have to knock out a molecule called CD7, which is a target for TALL. So to avoid fratricide, we have to remove CD7 first, then TCR alpha beta, then CD52 for alemtuzumab, then induced then transduced the CAR anti CD7 CAR. So this is the most complex manufacturing procedure we had to produce during the COVID, and we successfully produced this, and we infused first patient in 2022, and it was very successful. And the patient was 13-year-old girl, Alessia, and she's now doing very well. And so far, we have treated almost 7 patients, and I think the results are very encouraging with this off-the-shelf CD7 TALL CAR product. And after 2 years, Alessia is still completely in remission. So we are following up, and it was encouraging to see this kind of results with the allogeneic CAR T cells. And some of the results are already published. You can use this, and we have moved on to see how we can use this off-the-shelf CAR T cells for AML using dual target CD7 and CD33. This is in progress in GMP in UK. So that was my previous history. So now I moved to King Faisal in late 2021, where we wanted to establish our own point of care manufacturing in King Faisal. So we have designed a small lab to produce our CAR T cells, and we are running a couple of clinical trials. So this is one of the clinical trials where Dr. Riyad is main PI here for producing off-the-shelf CAR T cells, autologous CAR T cells in point of care manufacturing. So for that purpose, what we have done is we have designed a room for ISO 7, which is previously it was a pharmacy room, and utilized that the HVAC system, everything available in that room. So we designed this room. We have a here machine where we consider as a grade C area, and we have an anti room where we do our gowning, everything, and then we have a grade A area, which is a hood, where we do our kind of manipulations or media bag preparations, everything. Then we have a prototype machine where we produce the CAR T cells using this. So it was a challenging for us to develop a process because various logistics. The lab is situated in a hospital, so we cannot get the liquid nitrogen there for freezing the product. So we had to take the product once it's finished by manufacturing. So stem cell lab where we freeze that, where we have a liquid nitrogen tanks, and then after that, once we freeze, we release the product and then we infuse the patient. So this is at the moment we are in this stage. So this is a complex procedure, unfortunately, but it's doable. So we produce a couple of batches to see how logistically we can expand the cells properly on this prototype and make the doses relevant doses, and can we establish our release assays, all the release assays from quality control and vector copy number and RCL and potency, everything. So for that purpose, we have successfully produced a couple of batches, and we have seen the stability of these and expansion and transduction, very well transduction happening at 36%, and activation is happening in the cells. And the stability and viability of the cells are also good. This is the fresh product, and this is the after post thaw of 1 year. So 94 over 94% viability of the cells. So we have a little bit modified the protocol, what Multan is giving us. So what we're doing here is we are expanding the cells until day 8. If we have enough cells, we will stop the procedure here. Or if we don't have enough cells, we will proceed for day 12. So we made just some adjustment, so the option is available. So we don't want the cells to completely exhaust. So as I mentioned previously, we have produced 4 batches now successfully, and we are waiting for the patients to produce first patient batch. Hopefully by the next month, we will have a first patient infusion ready. So this is the IMPD was prepared, and IMPD was submitted to Saudi FDA and got approvals to produce the patients. And if you want more details of this large-scale for point-of-care manufacturing, we just submitted preprints last year, which will tell you every single details how we establish this, point-of-care manufacturing in Saudi Arabia. So that was kind of a, manufacturing in GMP. So other area what we are looking is to develop our pipeline using various modalities for various modalities. So for that purpose, what I'm using is I'm using T cells, NK cells, and we also started recently gamma delta T cells. And just to give you a brief overview of, we have multiple pipeline vectors for various indications, which I will show you in my next slides. But this was the first highlight I want to show you, where we have successfully developed a protocol to manufacture CAR T cells in 30 hours. So the advantage of that is multiple advantage, what I have mentioned here. The short manufacturing is good, which is cost effective, and it enhances the T cell fitness, and it keeps the prevention of stemness and preservation of stemness and memory phenotype, and it is giving low toxicity risk because of various things like novel domain and other things which I cannot discuss much about this. We are trying to paint this protocol, which we have I modified from the previous published protocols and extensively work on this to see how we can produce. And we have produced 3 batches successfully with 2 different vectors, which I'm going to show you some results on this. So this is the first short manufacturing, which using a Swift CAR platform for a T01 vector, which is a CD19 vector, is a novel vector. Various elements are novel in this, but the antigen binding domain is same like Kimra and Escata. So this product is giving very nice results and very nice transduction efficiency, and naive T cells we are able to preserve. And we have also checked how these cells do in potency, interferon gamma release on the TNF alpha, intracellular staining on Raji and Dowdy CD19 positive cells. So this is very well working on the. So this is a very preliminary data I'm showing you. Similarly, we have shown using the Swift CAR platform for AML. So this is the vector which we had already developed previously, targeting CD33. And we also have, which I'm not showing at the moment, we have discovered in King first time a novel AML CAR vector, which we are patenting. Unfortunately, I cannot discuss much until we have a final patent approval. So we just submitted patent application with PI as a Dr. Walid Warda in my lab, one of the brilliant scientists working with me. So we have a novel CAR for AML, first in the human, first in the world, and is a fully human CAR. So similarly, we have done some mice experiments using this T01. The vector is such a way designed that the vector can be used for autologous and allogenic. So that's the advantage of that. We have done using the T01. We have produced allogenic CAR T cells also. They're highly cytotoxic for CD19 positive cell lines, and mice model showing very clear, clear tumor clearance in day 28 and day 34. So with this, I just wanted to go some highlights. We have multiple pipeline vectors going on for various indications, mainly for BLL and TLL and AML and multiple myeloma. So I just want to switch gear here with the solid tumors.
One minute, Farhatullah.
Okay, yeah, I'm going to. There is a huge potential challenge we are facing with the solid tumors due to tumor microenvironment and antigen heterogeneity and on-target off-tumor effect. And it's also known that in Saudi Arabia, we have a lot of burden of triple-negative breast cancer mainly, and colorectal and thyroid cancer, which we projected to increase the numbers by 2030, and it's very, it's not looking good at the moment. So there is no approved product for any solid tumors. So what we are trying to achieve here is trying to achieve a multi-arm CAR platform where we can try to treat solid tumors by knocking out multiple targets and knocking in multiple targets, which I don't want to discuss too much at the moment, but we are working on it to see how we can produce this. So we have 4 vectors for this kind of targets, mainly triple negative breast cancer, colorectal, cervical cancer, and bladder cancers. Similarly, we have multiple vectors which we have not yet started working, but for sickle cell and hemoglobinopathies. And just wanted to highlight this. We have a big plan coming up to produce. We have our own GMP facility to produce this, kind of cell and gene therapy medicines in King Faisal. This is a very ambitious project for our institute. So I'm glad to say that we have a budget approval, and we are trying to establish this GMP facility to manufacture this. And with that, I will skip this slide. So we are trying to estimate how much, financially, how much budget we can save by producing these, products in-house. With that, thank you so much for listening, and I'm happy to take any questions. Thank you.
All right, we'll move to next speaker, Dr. Marco Rovella, well-known Amoral member of the King Faisal team and a member of a strong partner with us, UPenn program. Also, they are partners in this conference. Marco is, I've said, moral member of our team. He is in the lead of the lymphoma program at UPenn and world-renowned expert in developing advanced CAR T-cell therapies and innovative cellular therapies. Marco, welcome. He will give a presentation with the title Resistance to CAR T-cell immunotherapy for hematologic cancer.
Well, thank you so much for the kind introduction. It's so nice to be here again for the second time in Al Madinah. Salam alaikum. And I want to thank Dr. Amal and Dr. Ziad for the kind invitation. It's really a wonderful meeting that we are attending. So the title of my talk, so we're gonna give a back-to-back talk, and if you can please put also the slides on my screen. I still see Dr. Fartula. And I'm gonna give a back-to-back presentation. One is gonna be more focused on resistant mechanism to CAR T-cell therapy, and the second one is going to be more focused on how can we develop new approaches for overcoming resistance. So starting with the resistant mechanism, these are my disclosures that of course might affect some of the things that I'm gonna tell you, that especially in the setting of having patents that protect the intellectual property. And so I'm gonna be quick here, but I see that there are some students in the audience and maybe some junior folks. I wanted to go back a little bit to the basics. You can see here how the idea of a CAR came together. You can see it's a fusion between a monoclonal antibody and a T-cell receptor. And what you see here, it's a first-generation CAR, but the ones that are in the clinic are actually called second-generation CAR. And the main difference is the costimulatory domain that you can see here in yellow. For example, I'm showing you here the 4-1BB. Other products have CD28. So the ones that have been successful in the clinic so far and have been approved are a second-generation CAR. And again, we heard a lot about CAR T-cell and their biology. I want to show you some data on how they work in the lab. So you've seen in the previous talk the way we make CAR T-cell. There are different recipes, there are different ways, but basically the concept is that you take T-cell from a patient, most commonly use a lentiviral vector or a retroviral vector to bring the sequence of the CAR inside. And now the T-cell is gonna start expressing the CAR on the surface. And so that's really the product that we are going to infuse into patients. And once the product is infused, it's gonna recognize any cell that has CD19 expression on the surface, leading to the death of the tumor cell. And in the video that you can see here, you can see in red a CAR T cell that recognizes a tumor, and after a few minutes, this is a 15 minutes video, you can see that the tumor cell basically explodes. That's apoptosis. You can see all those bubbles, etc. So you can imagine that this was done in my lab, but it just shows what happened once you infuse the CAR T cell in the patient. They're gonna go around the body, find the cells that have CD19 positive, and kill them. And on top of that, the T cell can also proliferate and go around the body and find other tumor cells. And so thanks to this sort of concept that was pioneered by groups in Israel and in Japan in the 90s, then in the early 2000s, the first trials were done in the setting of first generation, didn't really work, and then several groups developed a second generation CAR, and in particular the University of Pennsylvania, the group of Dr. Karjun, developed Tisa-cel, or Kymriah, that then became the first product to be approved in the world as a CAR T-cell therapy. And you can see here, this is one bag of Kymriah, first approval in 2017. You can see that here. And then this was for pediatric acute lymphoblastic leukemia, and then more approvals. And so since then, what happened? Well, it has been amazing because over time, we got other products against CD19 to be approved. You can see here Axicel. This is the one developed by Kite with a CD28 co-stimulatory domain. You can see here in the bottom left. Then Brexcel, which is a similar product for mantle cell and adult leukemia. Breyanzi, which is an interesting product because it has the CD4 and CD8 separate expansion. And then we got two products for another target, for BCMA, for multiple myeloma. You can see the first one was ide-cel, and the most recent one is cilta-cel. And this was mentioned in the previous talk, the latest kid on the block is obe-cel. So this was developed in London and then by Autolus and was approved a few months ago for adult leukemia. So extremely exciting time because again, in 2017, in July 2017, there were no CAR product. Now a few years later, we have 7 products. But obviously today, I want to share with you what's next, right? But before doing that, I want to show you this picture, which I think is an interesting picture, just to tell you how many people worked at Penn for the approval of the first CAR T-cell product. This is all the CAR T-cell group from the regulatory, from the clinicians and people in the lab. And this was the day where Kymriah was approved by the FDA. And there was this big party. You can see probably somewhere here. I don't know if, yeah, you don't see my mouse, but you can see Karjun, etc. And of course, I was traveling to Italy, so I decided to Photoshop myself and to be part of the party, and now I'm over there. But it was a big, big celebration, of course, of the success of the team. But again, we're talking about CAR T-cell, and many people have presented new generation of CAR T-cell. Why? Well, because if we look even in the best case scenario, so B-cell lymphoma is probably the most common indication for CAR T-cell, especially large B-cell lymphoma. And you can see that using Kymriah, but the same results with the other products, we're really able to cure about 30% of the patient, 1 out of 3. And of course, that's amazing because these are patients that would be otherwise with a very poor prognosis. I think we can do better. I don't think we should be happy with a 30% at 5 years. And on the other side, this was mentioned earlier, the toxicity is still a problem. You can see in this schema that over time we have cytokine release syndrome, we have neurotoxicity, and most recently we've been talking about later toxicities of some of the BCMA CAR. So certainly that's also an issue. So really my team has sort of 2 main branches. One is thinking about resistance to CAR T-cell. The other one is the mechanism. And really when you understand this, you can develop novel approaches. So today I had 2 options. One was showing everything we do and 1 slide for each project. or telling you more about something that we're actually doing now, is unpublished and so on. So I decided to go just with one story of some work that we are doing now so that we can focus on that. But before doing that, I want to show you what we know so far about the resistant mechanism. So of course, it's our interest is improving the interaction between the CAR and the tumor. And so you would think that there are only two players, the CAR T cell and the tumor cells. But the reality is that it's way more complicated. It's more like this. And so why that? Well, because there are many factors that would affect how the CAR T cell and the tumor interact. And I always like to start, you can see on the top left, the issue of access and manufacturing. This was mentioned before. A therapy can be the best one, can be super effective, but if we cannot give it to our patient, well, it's worthless. And so the cost of CAR T cell is high, is about $500,000 in the US. We have issues with manufacturing in about 10% of the patient, and some patients cannot just get access to CAR T cell. I mean, here in Saudi, you have the leadership of King Faisal that has been getting CAR T cell in the clinic very early, and they have their own product, but many countries don't have CAR T cell. Even in the US, there are some of the states that don't have a CAR T cell center. So an issue of access is a big one. And then there are clinical factors. Of course, if patient has a very aggressive disease, we don't have time to give CAR T cell. But today I want to focus more on the biological reason. And so you can see I divided them in three main categories. One is shown here, is the CAR T cell dysfunction. Then we have the issue of the tumor microenvironment and the tumor intrinsic mechanism. A very common mechanism of failure is the loss of CD19. This was mentioned in the first talk by Dr. Nagat. Losing CD19 happens in about 30% of our patients. But T cell dysfunction is also an issue. So what do I want to show you? I show you some of the work that we've been doing over the years. We've been looking on apoptosis. So how to modulate, for example, BCL2 to improve CAR T cell. We've then done some work in trying to understand the microbiome. And so the microbiome is shown to have a role in CAR T cell therapy. We have done work on trying to understand the microenvironment, so how the interaction between the T cell and the tumor microenvironment may be affected. And in this paper here, we show that BTLA, for example, is an important checkpoint for CAR T cell. But we also done some work with epigenetic modulation. We heard from Dr. O'Connor in the session on T cell lymphoma how important it is for certain lymphoma to act at the epigenetic level. And so we've done work that is now in press in cancer cell, I don't think is out yet, where we looked at the EZH1 and EZH2 modulation during CAR T cell, and we showed that it's synergistic with the CAR T cell. So modulating the environment helps improving CAR T cell. And lastly, I don't have time today to show it to you, but we have done a lot of work on CD5 as a new checkpoint. So if you remove CD5 from the CAR T cell, you actually have a beneficial effect. But then, as I promised, I wanted to focus on one specific project today. And we have done some recent unpublished work where we look at co-stimulation. So I mentioned the interaction between the CAR and the tumor is essential. But it is not only about the CAR and CD19. There are other factors that would regulate the interaction between the CAR and CD19. And so we did a screening, a CRISPR-Cas9 screening, where basically we were trying to identify in the tumor cell, what are the genes that are needed for a good anti-tumor effect when they are co-cultured with CAR T cell. And so this library basically allows you to knock out one single gene in each cell, and the question would be, what gene is important for this interaction? And to make a long story short, we found many genes, but one of them, I think one of the most exciting one, was CD58. So in other words, if you don't have CD58 in the tumor cell, your CAR T cell are not going to work well. So what is CD58? Well, CD58 is an important protein that is expressed in lymphoma cells and in other tissues that interacts with CD2. So CD2 is an important co-stimulator in T cell. And so the interaction between CD58 and CD2 leads to activation, and so it collaborates with the TCR signaling to kill the tumor. And so Alberto and Matthew in the lab has been working on this project. So the problem with CD58 is that very often in the tumor, CD58 is lost. And so the loss of CD58 leads to potentially, we hypothesize, resistant to CAR T-cell because CD2 is not co-stimulating. And so we always like to start from patients, and so we look into our cases, and we did immunohistochemistry for CD58. And it was interesting to see that if you look at patient with the shorter response, so patient that relapsed very early, you can see there in the right column bar here. You can see that the ones that had a short response, they were the one with the lowest level of CD58 by immunohistochemistry. And you can see that when you look at relapse, a good portion of patients completely lose CD58 at relapse, meaning that this can really be a mechanism of failure of CAR T-cell. So we try to understand how CD58 affects CAR T-cell. So in the lab, we went back to the lab, removed CD58 from the tumor. You can see here the flow cytometry showing that we knock out CD58. And when you knock out CD58 using both a leukemia cell line, you can see NUM6 here, or a lymphoma cell line, OCLY18, in both cases, you can see that the anti-tumor killing of the CAR is reduced. So CD58 is really needed for the interaction. Furthermore, if we measure the interaction between the CAR and the tumor using avidity, so basically we let them attach to each other, and then we try to detach them. And so the strength that is needed to detach them is actually higher if you have CD58. If you lose CD58, as you can see in the schema here, you can see that basically you lose the potency of the interaction. And so obviously we try to go quickly to the mouse models, and in this case we remove CD2 from the CAR T cell. So we remove it from the tumor, it's bad. Now let's try the other side. And what you can see here is that if you remove CD2 from the T cell, and you can see in the light blue curve over here, you can see that the CAR T cells are no longer doing their job. And this is true for the tumor burden, but you also have a shorter overall survival there. So what happened to the T cell if they don't have this co-stimulation? Well, the problem is that they become more dysfunctional. And so we took the T cell from a mouse that was injected with a tumor, and we look at CD2 and mock. I wonder if you guys can put the laser pointer. Hey guys, sorry, can you put the laser pointer, the red one? Fantastic. So you can see here the CD2 and CD and mock CAR were infused, and then we look at the sequencing. And what you can see here is that, interestingly, that the CD2 knockout CAR, they started to show dysfunction. And you can see some of the critical checkpoint, like 3, but also other signs of dysfunction in the CAR T cell, meaning that really you need CD2 for a functional interaction. So how do we overcome this? Obviously, we cannot change the tumor. We cannot go inside and put CD58 in the tumor. I mean, we could hypothesize using all these in vivo technologies, but practically, it's easier to modify the CAR T cell than modifying the tumor. And so we came up with this idea. We thought, well, maybe if we don't have CD58, as you can see here, maybe we can develop a switch receptor that you can see over here, where instead of having the CD58 binding, which obviously is not available, we create a switch receptor that externally doesn't have CD2, but has PD-1, so it binds to PD-L1, and we know that PD-L1 is often expressed in lymphoma, and inside has CD2. So basically, we are tricking the CAR T cell to think that there is CD2 signaling when they recognize PD-L1. So we switch a negative signal into a positive. And you can see that the expression of this switch receptor is shown here to the right. And of course, we went right away to the mice, right? And so we used this switch receptor in a model where there is no interaction between CD2 and CD58. And you can see that, as we hypothesized, in purple, when you have a switch receptor in this group, you can see that the anti-tumor effect is much better than the wild-type CAR19, potentially suggesting that really the switch receptor is able to restore the function of this T cell. All right, so we show you that in the clinic CD58 is a problem. So we have a number of patients that lose CD58 at relapse. And we show that that leads to T cell dysfunction. So the CAR T cell are not able to kill the tumor to be co-stimulated as they should. And so we developed this switch receptor that potentially can restore the interaction between CD2 and CD58 by pretending that you're seeing CD58, but in reality, you're seeing PD-L1. And so, of course, what's next is to try to see if this is important not only in lymphoma, but also in solid cancer, obviously testing the CD2 switch receptor in other setting, other CAR T-cell product, and then the next step, of course, will be a clinical trial. So I can do the acknowledgement now, but this is my lab at Penn. I really want to thank Penn Medicine for the support and you know, the pipeline that we have to bring this stuff to the clinic. Carjun and CCI, the group in the lymphoma program, and all the funding agencies that you can see here, and thank to all of you for your attention. Do you want me to go to the next
please
talk?
So
wonderful.
Next talk titled Update on CAR T-cell Engineering, the Next Generation CAR T-cells.
Yeah, thank you. So we'll continue with, so we discussed about the resistant mechanism, right? So what are the most common mechanism? We say T-cell dysfunction, the tumor microenvironment, and CD19 negative escape on the tumor side, and we talk about the co-stimulation. Obviously now, you have heard in the previous talk, you have heard also yesterday other talks on sort of how to develop the next generation of products. I'm not gonna be able to go through everything that has been done so far. So again, also for this topic, I wanted to focus on a single project that is unpublished. And this project was only shown once before at ASH, the American Society of Hematology. This was in the plenary session. It was abstract number 4. And is a collaboration between our group and the group of Dr. Mayan Levy, who was at Penn and now is at Stanford. And you can see here Dr. Shen Liu and Dr. Punith Guruprasad led the efforts. So what can be next in CAR T-cell therapy? We have heard from the previous talk from Dr. Syed about the engineering. You can do a lot of CRISPR-Cas9 to improve your CAR T-cell. You can combine CAR T-cell with small molecules. You can make CAR T-cell recognizing multiple antigens. But for this specific project, we hypothesize, can the diet, so the food that we eat every day, the metabolites that are generated with diet, can that affect immunotherapy? And we show here, the question was, is diet something that matters? And so obviously to do that, we went back to the mice. We use an immunocompetent model of lymphoma, it's called A20, and murine CAR T-cell. So this is a fully immunocompetent model of CAR T-cell. And we gave to the mice different diets. So these are diets that are sort of recapitulating what are diets that are the most common one. So you can see the control diet to the left. You can see here, all the yellow is carbohydrate. And so typically we give mice a lot of carbohydrate and some fat. Then we gave a high fiber. So it's a lot of fiber in green and then some standard carbohydrate and some fat. And then high protein, you can see that the amount of protein in white is higher. Then so-called Western diet. Of course, we didn't give like hamburgers and fries to the mice, but we gave them a lot of fat, cholesterol that you can see here. Then high fat is basically very similar to the Western, just without cholesterol. And then we gave this diet that is called ketogenic diet. So it's a lot of fat, a lot of protein, and there is some people that do this ketogenic diet that because they say that they feel more energetic and so on. Of course, as an Italian person myself, I was rooting for the high fiber. I thought that the high fiber is the best, you should go with that, and it's very healthy. Even though I like pizza, I like pasta, so also the carbohydrates, of course, were in my short list. But the results were interesting, because when we give this diet to our mice, you can see here, we gave basically before giving the tumor and throughout the experiment. So they always had the same diet. When we measured the anti-tumor effect, really the best diet was the ketogenic diet. Was not the high fiber, was not the protein diet, was the ketogenic. So mostly fat and some proteins. And so why that? Well, it's interesting because when we look at the CAR T-cell proliferation, when we expose the CAR T-cell to a serum from mice receiving a ketogenic diet, they proliferated more. So the serum from ketogenic diet had something in them that made the T-cell proliferating more. And so what is that metabolite? What is leading to this increased proliferation? So we did metabolomics, so untargeted metabolomics on the serum. And a lot of targets came out as increase in the serum of mice receiving a ketogenic diet. You can see them, the blue dots, these are all the metabolites. But the one that was the single most enriched, because you see it's the one that is most to the right, was beta-hydroxybutyrate, or BHB. So this is a ketone body that is known to increase during ketogenic diet. And this was the top enriched metabolite in patients with actually mice with ketogenic diet. And so we tried to take this BHB and give it to CAR19 and see what happened. And BHB alone was able to increase proliferation of the CAR T cell. So again, going back, we defined BHB as the key factor leading to the increased proliferation of the CAR T cell. And so can we, instead of using a ketogenic diet that, to be honest, I never tried it myself, but it's hard to follow. You cannot have those fantastic dates that you guys are giving here. You cannot get all the sweets, etc. We hypothesized, well, maybe we can only give BHB to the mice and get the same effect. And as a matter of fact, we found that. So if you see here in blue is ketogenic diet, in red is BHB single agent, you can see that you get the same effect. So BHB alone is enough to lead to better anti-tumor effect. Again, these are the same CAR T cell, it's just changing the diet. Not gene editing, nothing, just changing the diet. And again, when you look at the CAR T cell, they seem to like it because they produce more cytokines. For example, these are the T cells that express both IL-2 and interferon gamma. You can see that they are much higher when you have either BHB or a ketogenic diet. So that was in a mouse model, mouse tumor, mouse CAR T cell. Of course, we care about human beings. And so we use a xenograft model where an immunodeficient mouse, the NSG mice, that they don't have a functional immune system, were injected with a lymphoma, or CLY18. This is an aggressive lymphoma, the LBCL. And then we gave them BHB, or of course control. And then we gave CAR T cell after a few days. So the idea, if we give BHB to these mice, what happens? And the results are shown here. So if you give the regular diet to mice, and you give T cell without the CAR, this is the blue line on top, the dotted line, the tumor progresses. If you give BHB alone, so you don't have effector T cell, only UTD, untransduced, there is not, like basically BHB alone doesn't do anything. If you give control diet plus nothing, and you use CAR19, well, of course, now some of the mice are starting to respond, and you can see some effect, but really minimal. We use a very low number of T cells. But when you give BHB to CAR19, you can see this dramatic effect where basically all mice were in complete remission. Only one was progressing. And so what's happening there? Well, again, as you saw in the mouse model, the fully murine model, we see the T cell proliferating more when you give BHB. So you can see day 7, day 14, day 21. Basically, we see huge expansion as compared to controls, only when you have BHB. So it almost seems like we're giving a fuel, some gasoline to this CAR T cell to do their job. And again, also in this model, more cytokines were found in the serum. I'm showing you interferon gamma here. So, of course, we wanted to understand more about the mechanism. What is mediating this improved effect of BHB on CAR T cell function? And so we did this study. It's quite complicated, but I'm going to walk you through is basically carbon labeling of this metabolite. So we gave to the cells carbon-labeled glucose and carbon-labeled BHB to see where those are integrated within the metabolic pathway. And you can see that it was interesting because if you look at all the substrate during the TCA cycle, you can see that all of them preferentially included BHB instead of glucose. And glucose really was mostly being used to make lactic acid. So the idea is that basically you're providing the CAR T cell with fuel that they can use right away to generate energy. And when you measure actually the metabolism of the CAR T cell, you can see that on top here in red, you can see that the metabolic pattern of the CAR T cell is higher. This is called, we have different things, I don't want to go too much in details, but the maximum oxygen consumption was higher in the CAR T cell as compared to the control. And you can measure that here. And now switching to going back to the patient, right? So we started from the patients, we went back to the lab, and now we are going back to the patients. We took the serum from patient receiving CAR-19. And of course, all of us, we have different diets, and so do patients. They have different diets. Some of them eat more fat, more proteins, more carbs. And we asked the question, if we look at the serum of these patients, can we see a correlation between BHB and proliferation of the CAR? And again, it's a limited number of patients, less than 20. But you can see that there is a trend, a clear trend, where if you have more BHB, this is the x-axis, you have higher proliferation of your CAR. And so again, suggesting that potentially there can be a correlation there. And so this was retrospective. Then we wanted to do a prospective study. And before getting into actual patient, we thought, well, we can use healthy volunteers. And why that? Well, because BHB is actually something that you can buy, for example, on Amazon. There are energy drinks that contain BHB. And so we bought that and we gave it to healthy volunteers, people in the lab, basically. A few people in the lab consented through an IRB-approved protocol to get a bolus of BHB. And we measured 90 minutes later the function of the T cell. And what was interesting to see that if you compare baseline and after 90 minutes, you can see that the healthy volunteers that were taking BHB, they actually had a better function of the T cell. You can see that the metabolism, this is again the oxygen consumption was higher, and also in general, the mitochondrial activity. So again, you're basically helping your T cell doing their job. And again, I mentioned there is a commercial, this is called, I don't have any conflict of interest with this specific product. It's called Ketone IQ. You can buy it on Amazon. And we thought, well, we can use that for a pilot clinical trial where we can actually give this Ketone IQ to patients with lymphoma that is going to receive CAR T cell. So now this trial is open. We are enrolling the first patient, so I don't have the results yet. But what I can tell you is that the idea that you can see in this schema is to enroll the patients before leukapheresis, getting the leukapheresis, but then after leukapheresis, starting giving BHB. And BHB will be continuously given for the first month of treatment. Patient will receive CAR T cell, and of course, we're going to measure if this is feasible, if this is safe, and then the next step, of course, will be to look at the efficacy. So this is led at Penn by Dr. Elise Chong. The trial is open, and of course, hopefully next year, I will give you some update on this clinical trial. Of course, we're going to look at the microbiome, the metabolites, and so on. So again, of course, this is one project that we're doing. We're doing many other projects. I want to show you just the pipeline for my lab of what we're taking to the clinic. I presented last year, we have now a CD5 CAR for T-cell lymphoma that's in the clinic. We treated the first patient, probably in the next couple of weeks, second patient, and we will give you an update, hopefully in a year or so. Second project is in the clinic, is this combination of BHP and CAR T-cell. But as mentioned, we're now developing other approaches. For example, we are developing BTLA knockout CAR30 for CD30 positive lymphomas. But also, as mentioned, we are looking at modulation of EZH1 and EZH2 for CAR T-cell therapy. Of course, those are the projects that I developed, but one of the reasons why Penn Medicine has been pioneering in the field of CAR T-cell is because we have a lot of trials. So these are all the trials that are today open at Penn for CAR T-cell therapy. I don't expect you, of course, to read through them, but it was just to give you a sense of
T-cell. So our next speaker is Dr. Riyad Al-Faqih, is a consultant hematology lymphoma specialist. He's also the chairman of clinical research department at King Fahd Medical City, Riyadh. Dr. Riyad will give a talk on real-world experience CAR T-cell in refractory relapse B-cell lymphoma from King Faisal Hospital.
Thank you. Thank you for the introduction, and I would like to thank the organizers for inviting me to present our real-world data in non-Hodgkin lymphoma. So, slides. Okay, so this is my agenda. I'll do a small introduction about the management of lymphoma in King Faisal, go over the registration trials in non-Hodgkin lymphoma, and finally go over our data. So this is how we manage early stage diffuse large B-cell lymphoma in our institution, and this is based on a number of trials done in this setting. So currently we do abbreviated R-CHOP for all patients except patients with bulky disease. So patients with bulky disease with a tumor more than 10 centimeter, we still do 6 cycles of R-CHOP and radiation therapy. Otherwise, we would do 3 cycles of R-CHOP, do a PET, and if the PET is negative, do 1 additional and stop without radiation. And this, we apply this for all age group, basically, in the institution. So for advanced stage, as you know, the standard still 6 R-CHOP. Too many trials tried to challenge the 6 R-CHOP, like dose-dense R-CHOP and CHOEP, but none of them was positive. As a matter of fact, 2 were positive, but did not become standard. One of them is RACVBP, which was superior to R-CHOP in terms of overall survival as well as CNS relapse, but did not become a standard because it's little toxic, more intensive, and some of the drugs are not widely available, like Vindizine. CHOEP did better than CHOP, but that's pre-rituximab era. The trial was not done after the introduction of rituximab. And as you know, many novel additions were added to the backbone of CHOP without clear benefit, like the robust trial R2-CHOP, Phoenix, ibrutinib, and CHOP. The only trial that was positive was the Polarix with 6% improvement in PFS in favor of Pola R-CHP. So as of now, our standard in the institution is still 6 R-CHOP. In patients with double hit by FISH, we would go for a more aggressive regimen, typically dose-adjusted REPOC. For relapsed refractory, the standard has been for more than 2 decades is salvage and autologous transplant, and this is based on the PARMA trial, as you see here, DHAB followed by a transplant, and respondents did better than DHAB alone. So post-auto relapse, you all know the patient did poorly before the introduction of novel therapeutics. You can see in this trial, this is focused on post-CAR T-cell relapse. And as you see, patients who relapse post-CAR T are the red curve, so very poor progression-free survival as well as overall survival. And that's because they did not have any option. Again, this is before the introduction of novel therapies. So this is where CAR T cell were invested initially, third line or post-CAR T cell relapse. And here you can see the 3 registration trials that led to the approval of different products in this scenario. So third line or post-autologous CAR T cell relapse. ZUMA-1 was the trial that led to the approval of axi-cel in the third line. And Juliet was the trial for TISA-cel, and Transcend 001 was the trial for Lysocell. And as you see, all trials, this is comparing trial to trial, not to head to head, but all of them seem to be similar in terms of efficacy. We have a flat curve running between 35 to 40%, and these are the people that probably are cured by CAR T cell. And that's what you expect when you use CAR second last line. So these are the first line. So these are the papers. They were all published in high-impact journals. And here you can see the end result of these trials. So in ZUMA-7, a PFS was demonstrated, and then later overall survival was demonstrated. Transform did show PFS benefit, and Belinda, unfortunately, was a negative trial, and that's the trial of TISA-cel. So why Belinda was a negative trial? Probably because of the long time to produce the cells. The average time took 60 days. And as you know, diffuse large B-cell lymphoma is not a disease where you can wait 60 days to treat your patient. So this is one of the major reasons why this trial turned to be negative, and as such, the drug was not approved. So based on these trials in the third line and the second line, here you can see the approved products available on the market. So as I mentioned, we have 3 products in the third line, TISA-cel, axi-cel, and Lysocell, and 2 products in the second line. These are axi-cel and Lysocell. So at King Faisal, our program started in 2020, and the first lymphoma patient was treated in January 2021. That was a third-line indication. At that time, we had TISA-cel available only in the institution. Since then, we treated 125 non-Hodgkin lymphoma patients. 22 of them were with TISA-cel, and the others were with axi-cel. So here you see our data. So we presented our data in different meetings in ASH, EBMT, and currently in EBMT, actually, we have our fellows presenting the data from our institution. So here you see the first 50 patients treated in the institution with axi-cel. So as you see, these patients were treated after introducing axi-cel from February 2023 to April 2024. Median age was 53, and all had good performance status. Median follow-up 7.6 months, and the median lines of treatment were 3. So around 40% had the product as an indication in second line, and 62% in third line and beyond. 16% of these patients had autologous stem cell transplant. Their median inpatient stay was 26 days, and 80% had a histology of diffuse large B-cell lymphoma, while 10% had a transformation from other type of lymphoma, and 10% had a primary mediastinal B-cell lymphoma. So before CAR T-cell therapy, 90% of the patients did have advanced stage 3 or 4, and 12% of the patients had CNS disease prior to CAR T-cell treatment. So here you see the day 30 overall response rate of these 50 patients, 52% CR, 80% overall response rate, and 16% progressive disease.
If you look into second line and third line specifically, so the overall response rate was similar, 79% and 80%, but the CR rate was higher in the second line, 58% versus 48%. 12-month overall survival in the overall population was 75%. If you look into second versus third line, so the second line patients had much better survival, 94.7% at 1 year versus 68.5%. And the day 30 CR survival was 91% at 1 year. So these people, these patients who went to CR did much better, regardless in the second or the third line. The 12-month PFS was 55%, with 56.8% for patients who received the product in the second line and 53.8% for patients who received the product in the third line. Day 30 CR patients did much better in terms of PFS, so the PFS at 12 months was 75%, and that's regardless if they received the product in the second or the third line. We had 4 patients with T-cell, rich B-cell lymphoma, and they did not do well, actually. So 3 patients went into partial remission and progressed eventually, and 1 patient had progressive disease. 19 patients relapsed post-CAR T-cell, so out of the 50, 19 relapsed, and 14 of them received bispecific antibodies. And you see here the overall response rate to bispecific was 43%, 6 out of these 14 patients, and 1 of them only had CR, so not very impressive results, 7% CR. At 3 months, the overall survival of patients who received the bispecific was better than the others. Whether this is selection bias, these patients were selected because they were doing well, and then they were selected to receive treatment, or not, we don't know, but they did better than the others. So in terms of toxicity, CRS happened in 92% of the patients, and it was similar in second or third line. The majority of the CRS was grade 1 to 2, as you see, 88%, and 4% only were grade 3 and 4. Now, the overall survival per CRS grade, as you see, patients with higher CRS grade did much worse than patients with lower CRS, and this is probably from the mortality resulting from the CRS and the treatment of the CRS and the higher grade patients. ICANS happened in 19 patients, and it was more frequent in the third line. 22% were grade 1 to 2, and 16% were grade 3 to 4, with no difference in the overall survival in between higher and lower grade CRS patients. So here, if we compare to the registration trial, this is King Faisal data, this is ZUMA-7, so this is in second line patients. As you see, the overall response rate is near to the ZUMA-7. PFS at 12 months, 58% for ZUMA-7 and around 57% King Faisal. Overall survival, 76% in ZUMA-7, 94 in King Faisal. And why we have 94, way much better than ZUMA-7, because we had access to biclonals, and these patients received biclonals, so they did survive longer than the ZUMA-7. If you see toxicity, grade 3 CRS, 6% in Zuma, 4% in King Faisal. Grade 3 and above ICANS, 21% in Zuma 7, 16% at King Faisal. So pretty much similar efficacy and lower toxicity in our population as compared to the registration trial. If you look into third line and beyond, so comparing to Zuma 1, a similar population, you see the overall response rate is 82% versus 80 at King Faisal, 42% CR rate versus 32 at King Faisal. PFS, 44% in Zuma 1 versus 53.8 at King Faisal. This is at 1 year. Overall survival, 59% in Zuma 1, 68.5 at King Faisal. Toxicity, again, grade 3 and above toxicity was 6% in the registration trial versus 4% at King Faisal. Grade 3 and above ICANS, 21% in the registration trial, 16%. So pretty much lower toxicity, similar, if not better efficacy in our cohort of patients. The other thing we analyzed is radiation before CAR T cell. So as you see, many groups reported that bridging with radiation leads to better outcome in CAR T cell. So out of these 50 patients that we treated, 13 received bridging radiation, and these were presented as an ASH abstract this year, their outcomes compared to the ones who did not receive. So comparing the baseline characteristics, both groups were similar. The median age was 53 years, and the majority of patients received CAR T cell as a third line, 69%, and the median radiation dose was 28 grays, median fractions were 10, and the major site or the majority of patients received radiation to the mediastinum. The second most frequent site was CNS, and the third was different places actually in the body. Here you can see the results. So the overall response rate at day 90 was higher in the radiation group, as well as the CR rate, overall survival, and PFS. So all the values were in favor of the radiated group. CRS was higher in the radiated group, as all patients did develop CRS. ICANS also was a little higher in the radiated group. Now, if you look at the PFS, it was not statistically significant. This is a small number of patients, again, 13 patients, but you can see a trend. Now,